What if the entire human body could be learned step by step, from its simplest shapes to its most complex systems? Why do so many students feel lost when the body's map seems too overwhelming to follow? And if anatomy is built like levels in a game, then how far can you climb before the pieces connect into one complete picture? Welcome to Rest Academy. Tonight we'll explore anatomy from level 1 to level 100, beginning with planes and positions, moving through tissues and organs, and ending with the complete integration of all systems. Because these ideas are heavy to hold, I've prepared a free practical guide. You'll find it in the description, like a map you can return to whenever you need it. So take a slow breath. Tonight we begin with the first 4 levels: foundations, tissues, skin and fascia, and bones. Your mind pictures a body on a table under soft light. To speak clearly about any structure, you first agree on a shared orientation, like unfolding a city map. Anatomical position is that map's north. You imagine the person standing upright, facing forward, arms at the sides with palms forward, feet together or slightly apart, and head level. This standardized pose fixes left and right from the subject's perspective, not yours. Why it matters is simple. Without it, lateral becomes a guess, and guesses break safety. When a radiograph is read or a procedure is consented, that quiet agreement removes ambiguity, so language can target a single place every time. Once orientation is fixed, you slice the map into predictable views called planes. A sagittal plane divides left from right. A mid-sagittal cut runs straight down the center, while parasagittal slices sit beside it. A coronal plane, also called frontal, divides front from back, revealing how the ribs curve and how the lungs sit behind the sternum. A transverse plane, also called axial or horizontal, divides top from bottom and is the workhorse of cross-sectional imaging, where the liver's right lobe appears as a familiar crescent and the vertebral body as a round column. Each plane highlights relationships that vanish in the others. Movements are described relative to these planes. Flexion typically occurs in a sagittal plane, abduction in a coronal plane, rotation in a transverse plane. You can feel this organization in your shoulder as you lift, abduct, swing, or twist, rotate the humerus along those implied sheets. With a compass and grid in place, directional terms turn the map into coordinates. Superior means toward the head, inferior toward the feet. Anterior is toward the front of the body, posterior toward the back. Medial points toward the midline, lateral points away. Proximal and distal track closeness to a limb's root, so the elbow is proximal to the wrist but distal to the shoulder. Superficial indicates nearer the body surface. Deep goes inward toward the core. These paired words reduce whole sentences to a phrase. A superficial laceration over the anterior, lateral forearm instantly narrows where to look and what layers may be involved. In the hand and foot, you also borrow dorsal and palmar plantar to respect local tradition. In the skull, rostral and caudal sometimes refine head-specific direction. The vocabulary is small, but its clarity saves time. Beneath the surface, space is organized into cavities, large internal rooms that house organs and permit movement with minimal friction. Posteriorly, the cranial cavity encloses the brain, and the vertebral canal protects the spinal cord. Both are stiff-walled by bone and wrapped in meninges, a triple membrane that suspends delicate tissue and channels fluid. Anteriorly, the thoracic cavity is framed by ribs, sternum, and thoracic spine, then divided by the mediastinum, a central corridor holding the heart, great vessels, trachea, and esophagus. On either side, right and left pleural cavities shelter the lungs inside pleuri. Thin serous membranes that create a moist, low-friction interface so each breath can glide. Below the diaphragm, the abdominopelvic cavity extends as a continuous volume but with distinct neighborhoods. The abdominal cavity, lined by peritoneum, cradles stomach, intestines, liver, spleen, and more. The pelvic cavity protects bladder, reproductive organs, and rectum within a bony bowl. The peritoneum reflects to form mesenteries, double layers that suspend viscera, carry vessels and nerves, and allow controlled mobility like organized wiring behind a wall panel. Think of the whole arrangement as a well-surveyed campus. Anatomical position sets the campus orientation. Planes are the floor plans, directional terms are the room numbers, cavities are the buildings with corridors, and mechanical spaces. Because you can reference the same north, the same third floor, east wing, professionals from different rooms, radiology, surgery, emergency care can coordinate without stepping on each other's lines. Even in daily life, you use the scheme without noticing. When you describe a knee ache as deep and medial, you already moved from vague to precise. Mechanically, this precision protects function. In the thorax, a small change in the pressure of a sealed pleural cavity alters lung inflation. Knowing the cavity's boundaries helps explain why air introduced into that space collapses the lung. The tissue falls away from the chest wall when the lubricated seal is lost. In the abdomen, pain that starts vaguely near the umbilicus and migrates to the right lower quadrant maps visceral to parietal peritoneal irritation. The shift reflects different sensory wiring and sharper localization in the parietal layer. In the skull, directional terms refine imaging findings. A lesion posterior to the clivus means something different from superior to the sella, and those prepositions guide both urgency and approach. The words are tiny, but they carry real consequences. Consider a brief bedside scene. You are handed a chart stating, cut on arm. That label is useless. You clarify which arm, which surface, how deep, any numbness. The patient shows a 2 cm superficial laceration on the anterior, lateral aspect of the right forearm, distal to the elbow. Instantly you infer likely layers affected: skin, superficial fascia, structures spared, major arteries lie deeper and more medial, and which nerves to test: lateral, antebrachial, cutaneous. If the person instead reported immediate weakness in wrist extension or numbness over the first dorsal web space, your mental compass would swing posteriorly and proximally to consider radial nerve injury at the spiral groove. Language starts the diagnostic path before any instrument appears. Occasionally, the map signals danger: a sudden worst headache, stiff neck, or altered awareness in someone you are describing with cranial or meningeal terms is a cue for urgent evaluation by a qualified professional. New loss of sensation or weakness that obeys a recognizable directional pattern: one side of the body, unilateral, one limb becoming heavy, distal to proximal, or a sensory level on the trunk, also deserves prompt medical care. The vocabulary helps you notice patterns. Responding to them requires clinical judgment beyond this calm study. You might pause and test your bearings. If you imagine a coronal slice through the chest at nipple level, what lies anterior versus posterior? You can place the sternum anteriorly, the heart centrally but slightly left of midline, the vertebral bodies posteriorly, lungs flank the heart laterally within pleural cavities. If someone rotated the image 90 degrees, the terms still hold because they fix to the subject, not to your screen. This constancy is why radiology labels R and L feel so reassuring. They anchor you back to the standard pose. A short reflection: once the map is clear, subtle details become peaceful to learn. Certainty about where you are lowers the noise in your thinking. You feel room open for curiosity rather than urgency. Quiet confidence grows when space makes sense. With your compass steady, you're ready to ask what the body is actually made of, what 4 materials repeat, and how one of them quietly shapes movement while appearing to simply connect everything. Your fingertips rest on a smooth countertop. Beneath your skin, 4 materials quietly negotiate contact and pressure, so nothing tears. You learn their roles the way you would learn a building's components: facade, frame, motors, and wiring, each distinct, yet nothing works alone. Epithelium is a continuous sheet of tightly packed cells that covers surfaces and lines, cavities, forming a selective boundary. These cells have polarity: an apical side facing the outside world, or a lumen, and a basal side anchored to a basement membrane, a thin specialized matrix that secures the sheet to underlying support. The tightness of the junctions between epithelial cells varies with function. In the small intestine, tight junctions form controllable seams that admit nutrients and water. In the urinary bladder, junctions tighten further to resist leakage under pressure. Intercellular structures, tight junctions for sealing, adherence junctions and desmosomes for mechanical coupling, and gap junctions for small signal sharing, turn an array of cells into a coordinated barrier that can flex, stretch, or fold without splitting. Apical specializations refine function. Microvilli, tiny projections that increase surface area, amplify absorption in the gut. Cilia, motile hair-like organelles, move mucus across the airway and sweep ova along the uterine tube. The basal surface attaches to the basement membrane through hemidesmos, anchoring the sheet to a stable foundation. When epithelia invaginate and specialize, they form glands. Exocrine glands deliver substances to a surface through ducts, while endocrine glands release hormones into the blood. Across these forms, epithelial turnover is measured and constant. Stem cells restore worn cells so the facade stays intact despite constant exposure to friction, acid, light, and microbes. Connective tissue is the frame and filler that holds everything in place and crucially distributes force through a hydrated matrix. Unlike epithelium, its cells, fibroblasts, adipocytes, immune cells sit farther apart, suspended in extracellular matrix (ECM). The ECM includes fibers and a ground substance. Collagen provides tensile strength, elastin confers recoil, reticular fibers form delicate scaffolds for cellular neighborhoods. The ground substance is a gel made of glycosaminoglycans and proteoglycans that binds water. It resists compression, permits diffusion of nutrients, and because it is deformable yet continuous, transmits mechanical load like grout sharing stress between tiles. Loose areolar connective tissue cushions vessels and nerves. Dense regular connective tissue organizes collagen in parallel bundles for tendons and ligaments. Dense irregular tissue forms multidirectional sheets in dermis and organ capsules. Some connective tissues mineralize, bone. Some are avascular and resilient, cartilage, and one flows blood. Each still fits the same principle. Cells maintain an ECM tailored to local demands. Fibroblasts sense strain and remodel collagen alignment. Osteocytes sense load and direct bone turnover. Chondrocytes maintain cartilage's firm but compressible matrix. During repair, fibroblasts may adopt contractile features as myofibroblasts, drawing wound edges together while laying down collagen. If signaling overshoots, scarring and stiffness follow. If signaling falters, instability or non-healing results. The frame is alive, and it listens to use. Muscle tissue supplies motion. It is excitable and contractile, converting chemical energy to force, using actin and myosin proteins arranged into repeating units called sarcomeres. In skeletal muscle, long multinucleated fibers show striations under the microscope. They attach to bones via tendons and move joints under voluntary control. Contraction begins when a motor neuron releases transmitter at a neuromuscular junction. An electrical impulse spreads along the muscle fiber membrane, dives through T-tubules, and triggers calcium release inside. Calcium binds to troponin, shifting tropomyosin off actin's active sites so myosin can cycle, generating force and shortening. Cardiac muscle is also striated, but forms branching cells linked by intercalated discs, mechanical anchors, and electrical gap junctions that synchronize contraction. Intrinsic pacemaker cells generate rhythmic impulses. Conduction pathways coordinate chambers so filling precedes ejection. Cellular mitochondria are abundant. Sustained, oxygen-dependent energy suits a pump that cannot rest. Smooth muscle lacks striations. Its actin and myosin are arranged differently and are regulated by calcium calmodulin activation of myosin, light chain kinase, found in vessel walls, airways, the gut, and the uterus. Smooth muscle sustains tone, modulates diameter, and produces slow waves and peristaltic patterns under autonomic control. Across all types, the generated force must leave the cell. Cytoskeletal linkages tie contractile threads to the cell membrane and to surrounding connective tissue, so tension flows into tendons, fascia, and ultimately bone or organ walls. Nervous tissue is the control wiring that senses, decides, and commands. Neurons are specialized cells with dendrites receiving input, a soma integrating signals, and an axon conducting action potentials to distant targets. These impulses arise when voltage-gated ion channels open in sequence. The wave propagates without fading, arriving at synapses where chemical transmitters cross a narrow cleft to influence the next cell. Some synapses are electrical through gap junctions, enabling rapid synchronization. Supporting glial cells outnumber neurons and are essential. Astrocytes regulate the chemical environment and form part of the blood-brain barrier. Oligodendrocytes, central, and Schwann cells, peripheral, wrap axons in myelin to speed conduction. Microglia survey for damage and respond to threats. In the periphery, sensory neurons detect mechanical, thermal, and chemical changes. Motor neurons connect to skeletal muscle fibers, forming motor units whose size sets precision versus strength. When you assemble these four materials into an organ, their cooperation becomes plain. consider the small intestine. Epithelium with densely packed microvilli absorbs nutrients. Just beneath, connective tissue in the lamina propria supports capillaries and immune cells. Smooth muscle layers generate peristalsis. Intrinsic enteric neurons coordinate local reflexes even without conscious input. Or consider a tendon. Dense regular connective tissue aligns collagen cables at the junction with skeletal muscle. The muscle's contractile apparatus hands force to a continuum of connective tissue layers, endo, peri, epimysium into the tendon, and then into bone's mineralized matrix. The gel of ground substance and the weave of collagen do not merely fill space, they route and temper load so motion feels smooth rather than brittle. A brief bedside scene clarifies the materials at work. After a sudden ankle twist on uneven ground, swelling rises along the outer joint. Dense regular connective tissue in the lateral ligaments has been strained. Collagen fibers that prefer parallel tension now face abrupt torsion. Ground substance draws water, producing a soft pitting fullness. Small vessels leak, and local nerve endings signal sharp pain with specific movements. Skeletal muscles around the joint contract reflexively to guard the area, while sensory neurons report position error to the spinal cord. If the foot turns pale or cold, if numbness spreads, or if you cannot bear any weight, these are concerning signs that warrant prompt evaluation by a qualified professional. Structure and function can be preserved best when serious injury is recognized early. A short reflection. Knowing the facade, frame, motors, and wiring quiets the puzzle. Materials explain patterns, why a surface heals quickly, why a ligament stiffens with disuse, why a rhythm can falter yet recover when connections realign. You sense the whole building breathing, surfaces exchanging, frames sharing load, motors humming under quiet control, wiring tuning response. Now your attention moves outward to the body's largest interface and the thin, organizing films beneath it, layers that protect, patterns that guide incisions, and subtle lines that predict how tissues glide when you turn in bed. You run a fingertip along your forearm and feel a smooth sleeve that hides layered tailoring. 4 components shape this protective suit and its quiet gliding: the epidermis as the weatherproof outer cloth, the dermis as the tough woven backing with guidelines, the subcutaneous layer as the padded lining, and the deep fascia as the fitted inner shell that lets everything move without snagging. The epidermis is a stratified squamous epithelium, the body's outermost sheet of cells that forms a barrier against water loss, friction, and microbes. Its main cell, the keratinocyte, matures as it rises from the basal layer toward the surface, accumulating keratin and forming intercellular junctions that tighten the seal. By the time keratinocytes reach the top, they have become flattened, enucleate corneocytes that interlock like shingles. Melanocytes, which reside in the basal layer, distribute melanin granules that absorb ultraviolet radiation, shading nuclei below. The pattern of this pigment can vary widely, yet serves the same protective logic. Langerhans cells, specialized immune sentinels, sample the environment and present antigens, linking the skin's frontier to the broader immune network. This outer cloth is thin but not fragile. Its strength comes from layered organization and from its partnership with the dermis beneath. A functioning barrier means selective passage. Tight junctions limit uncontrolled water flux. Lipids secreted between cells form a mortar around the corneocyte bricks. Desmosomes lock neighbors together, resisting shear. When the seal loosens after prolonged moisture, harsh solvents, or inflammation, the surface may fissure and sting because exposed nerve endings in the underlying tissue now receive mechanical and chemical cues they should not. Ridges and appendages add local nuance. Hair shafts emerge through pores. Sebaceous glands lubricate. Nails protect distal digits as stiff plates derived from keratinizing epithelium. Even this outermost layer influences how force feels. A callus, for example, thickens the stratum corneum under repeated pressure, redistributing load over a larger area so friction irritates less. Beneath the epidermis lies the dermis, a dense connective tissue layer that gives the skin its tensile strength and elasticity. Collagen fibers, especially type 1, run in organized bundles. Elastin fibers weave recoil into the fabric so the cloth snaps back after stretch. The dermis has 2 zones, a superficial papillary layer with delicate looping capillaries and fine collagen, and a deeper reticular layer with thicker bundles and fewer cells. Vessels within the dermal plexuses feed the epidermis by diffusion and help regulate temperature by shunting flow toward or away from the surface. Sensory end organs, Meissner corpuscles for light touch in the papillary dermis, Pacinian corpuscles deeper for vibration and pressure, translate mechanical deformation into nerve impulses. The dermis is where small tears or overstretching can leave lasting marks. When collagen bundles remodel under rapid growth or hormonal change, linear depressions we call stretch marks trace the line of least resistance. Within this woven backing lie patterns that guide incisions and explain scar behavior. Langer's lines, also called cleavage lines, are skin tension lines that follow the prevailing orientation of dermal collagen. They arise because collagen bundles align along habitual stretch and compression directions in a given region. When a cut parallels these lines, opposing dermal fibers pull less, resulting in a finer scar. When a cut crosses them perpendicularly, retraction is greater and the scar tends to widen. Surgeons study these lines not because they are absolute, individuals vary, but because they reduce guesswork. The fabric's weave tells you where it prefers to lie flat. On the face and palms, additional patterns like relaxed skin tension lines or flexion creases refine the map. The garment shows its seams if you know how to look. Below the dermis, the subcutaneous layer, also called the hypodermis, contains adipose lobules separated by fibrous septa within a matrix of loose connective tissue. This padded lining insulates, stores energy, cushions against impact, and most importantly creates a mobile interface that lets the skin glide over muscles and tendons when you move. Superficial veins and lymphatic channels traverse this layer. Their course explains why swelling after an ankle twist sits soft and mobile, and why dependent regions may show pitting when fluid accumulates. Because the subcutaneous layer is compliant, it can also be a highway for spread. Infections that enter here may extend along the fat's relatively avascular planes unless the immune system arrests them. The pattern of fibrous septa differs by body region, sex, and age. These differences influence how the surface dimples, how heat is retained, and how drugs delivered into this layer are absorbed compared with injections placed deeper into muscle. Deep fascia, finally, is a tougher, denser connective tissue sheet that invests muscles, forms intermuscular septa, and creates osteofascial compartments in the limbs. Think of it as the suit's fitted inner shell. It keeps muscle bellies in place, provides firm surfaces for muscles to push against, and directs force along predictable paths. Where tendons cross joints, thickenings of deep fascia form retinaculum, restraining tendons close to bones so they do not bowstring during motion. This is why you can flex and extend your fingers smoothly without cords popping away from the wrist. Between muscle and deep fascia lies a thin, slippery areolar layer that promotes gliding with minimal friction. When inflamed or dehydrated, this glide plane binds and movement feels stiff or burning. Neurovascular bundles often run in fascial planes because the path is protected. This is efficient but has a trade-off. Bleeding or infection can track along the same low-resistance routes. In the abdomen and neck, named fascial layers create defined spaces. Knowing them explains how a dental infection, for instance, can descend into deeper compartments if not controlled. These layers act together whenever you reach, step, or turn in bed. The epidermis resists abrasion from sheets. The dermis transmits shear while guiding how a cut would pull. The subcutaneous layer allows the surface to slide without tearing deeper. Anchors, the deep fascia coordinates the motion underneath and keeps the machinery aligned. Because the garment is continuous, local changes ripple outward. A tight scar tethering dermis to deep fascia can distort motion across a joint. Swelling in subcutaneous tissue can compress superficial nerves and create tingling. Inflamed fascia can alter muscle recruitment so other areas compensate. A bedside vignette brings the tailoring into focus. After a small kitchen knife slips, a short cut appears over the palm, crossing one of the natural crease lines at a sharp angle. Bleeding is modest. The superficial epidermis and dermis gape because the incision runs perpendicular to local tension lines. The edges seem unwilling to meet. Gentle pressure reduces bleeding, but pain intensifies when the finger is extended. You examine for function, flexion is intact, sensation over the fingertip persists. If numbness had appeared on one side of the finger, if active flexion had failed, or if the wound had exposed pale tendon, concern would rise for deeper structure involvement, injuries that require prompt professional evaluation to protect long-term motion and sensation. Another scene. A warm, tender redness spreads along the forearm skin over hours, accompanied by fever and malaise. If pain becomes severe out of proportion to the surface findings, if the skin turns dusky or blistered, or if you notice rapidly advancing borders, these are urgent warning signs that demand immediate medical care because infections can travel along fascial planes and compromise deeper tissues quickly. A brief reflection settles you when you know the garment's cloth, weave, padding, and fitted shell. You understand why a small change in one layer can echo as stiffness, altered sensation, or visible pull elsewhere. You feel the sleeve flex smoothly as you move, seams cooperating, layers gliding, the whole suit quiet but alert. Now you're ready to look beneath the fabric at the frame that shapes the suit, a living mineral that senses load, remodels with use, and hides a lattice more dynamic than it first appears. You lift a smooth river stone and feel weight that seems permanent. Inside your skeleton, a similar mineral feels alive because a hidden crew is always inspecting, carving, and rebuilding the scaffold while you move. 4 ideas anchor this frame: structure, growth, remodeling, and types. Structure first. Bone is a composite material. An organic matrix of type I collagen fibers provides tensile strength and flexibility, while inorganic crystals of calcium phosphate, chiefly hydroxyapatite, stiffen the matrix against compression. The partnership matters. Collagen without mineral bends, mineral without collagen shatters. The composite resists both. 2 architectural arrangements distribute this material. Cortical compact bone forms dense outer walls of shafts and cortices. Its cylinders, called osteons, arrange lamellae around haversian canals that carry small vessels and nerves. Concentric lamellae orient collagen fibers in alternating directions, resisting crack propagation the way plywood resists splitting. Tiny transverse channels, Volkmann canals, link neighboring osteons to the periosteal and endosteal surfaces, completing a service corridor for nourishment and repair. Trabecular spongy bone fills the ends of long bones and the interiors of vertebrae and flat bones. It organizes into struts and plates called trabeculi that align along habitual lines of stress. The spaces between trabeculi contain marrow, hematopoietic tissue in many axial locations, so the scaffold both bears load and hosts blood cell production. At the outer surface, periosteum, a fibrous layer rich in vessels and sensory nerves, sheaths the bone. Its inner cambium layer houses progenitor cells that can become osteoblasts. On the inner surfaces, endosteum lines canals and trabeculi with a thin, active layer of cells, setting the stage for interior adaptation. Osteocytes, the most numerous bone cells, sit in lacunae within the mineral matrix and extend long processes through canaliculi, forming a fluid-connected network. These resident sensors detect strain and microdamage and relay signals that govern where and when the crew should work. Growth next. 2 blueprints build bone in the embryo and continue to influence later changes. Intramembranous ossification forms bone directly from mesenchymal tissue. Clusters of progenitor cells differentiate into osteoblasts, secrete osteoid unmineralized matrix, and mineralize it, expanding and fusing centers to build flat bones of the skull and part of the clavicle. Endochondral ossification uses a cartilage model first. Chondrocytes enlarge hypertrophy, the matrix calcifies, and blood vessels invade, bringing osteoblasts that lay bone on the remnants of cartilage. This method builds most long bones. After birth, lengthening of long bones proceeds at the growth plate, epiphyseal plate, a specialized cartilage zone between epiphysis and metaphysis. Within it, organized layers create forward motion. Resting chondrocytes hold potential. Proliferating cells stack into columns. Hypertrophic cells swell, alter matrix chemistry, and prepare it for calcification. Then vascular invasion replaces cartilage with bone on the metaphyseal side. The plate advances away from the metaphysis as long as cartilage production balances replacement. When hormonal and genetic signals close the plate, longitudinal growth ceases. Meanwhile, appositional growth thickens bone by adding new layers under the periosteum and resorbing endosteal bone to maintain appropriate canal size. The overall geometry shifts to meet changing mechanical demands as body mass and activity patterns evolve. Remodeling is the lifelong maintenance cycle that renews bone, repairs microdamage, and optimizes architecture for current loads, while also serving mineral homeostasis. Basic multicellular units, BMUs, carry out the work. Osteoclasts, multinucleated cells derived from hematopoietic lineage, attach to bone surfaces, create a sealed resorption lacuna, acidify it to dissolve mineral, and secrete enzymes to digest collagen, leaving small pits or tunnels. Then osteoblasts, matrix-secreting cells from mesenchymal lineage, arrive to lay down osteoid, which later mineralizes. Some osteoblasts become osteocytes, embedding as new sensors, others become quiescent lining cells. The sequence is orderly: activation, resorption, reversal, formation, and quiescence. What starts and stops the crew? Mechanotransduction is central. When you load bone, fluid moves through canaliculi. Osteocytes sense this shear and adjust signals, reducing inhibitors of formation such as sclerostin and promoting pathways that favor osteoblast activity, so formation outpaces resorption, where strain is useful. When loading falls, the opposite signals relax restraints on resorption. Local microcracks also alert osteocytes. Damaged cells undergo controlled death, and neighboring cells release cues that recruit osteoclasts to remove compromised tissue. Systemic hormones modulate the balance to stabilize calcium and phosphate in the blood, but the details matter less here than the principle. The skeleton listens to use and to the body's mineral needs, then negotiates a compromise that protects both structure and chemistry. The result is a moving average, not too dense where weight would be wasteful, not too sparse where strength is needed. The last concept is types, which organizes the catalog. You classify bones by shape and by tissue architecture. Shape first. Long bones, femur, humerus, have a shaft, diaphysis, and ends, epiphysis, for leverage and load transfer. Short bones, carpals, tarsals, concentrate spongy bone under thin cortices to absorb compressive forces in compact joints. Flat bones, sternum, skull, ribs, provide broad surfaces for muscle attachment and protect vital organs. Irregular bones, vertebrae, facial bones fit special roles with complex processes. Sesamoid bones, patella, form within tendons where they cross joints, improving leverage and modifying applied forces. Architecture second. Cortical bone dominates where bending and torsion must be resisted by thick walls. Trabecular bone dominates where multidirectional forces and shock absorption matter. Its alignment a record of the usual stresses experienced. Across types, the periosteum's innervation explains why fractures hurt sharply, and the endosteal and marrow environments explain why healing and blood formation are so closely linked. Consider how the four ideas cooperate when life changes. In a new weight-bearing exercise habit, load increases at particular regions. Osteocytes sense fluid shifts, decrease local inhibitors, and bias BMUs toward formation along trabeculi that align with the repeated forces. Periosteal apposition may thicken cortices subtly over months, and microscopic architecture tightens, improving stiffness without heavy mass gain. Conversely, prolonged unloading during bed rest changes signals. Bone loss occurs fastest in regions accustomed to higher strain. Trabecular-rich sites like the vertebral bodies and the femoral neck adapt downward, showing that use it is not a slogan but cellular negotiation. Age, hormones, nutrition, and inflammation nudge the balance. The skeleton's response is real-time, never finished. A bedside scene tests the framework. After a low fall, an older person develops groin pain and cannot bear weight. The leg lies slightly shortened and externally rotated. The periosteum screams, surrounding muscles spasm to guard, and small vessels within the femoral neck region face interruption. If pain is severe with minimal trauma, if deformity appears, if you notice numbness, pallor, or loss of distal pulses, or if fever and deep constant night pain coexist with localized bone tenderness, these are concerning signs that call for prompt professional evaluation. Stability and blood supply decide long-term function, and timing often matters. Another scenario, a child with focal bone pain and swelling near the knee end of the femur shows tenderness over metaphyseal bone. Growth plates are zones of high cellular turnover and altered blood flow, which can influence how infection or other processes behave. The frame carries life, so warnings deserve attention. A brief reflection: bone feels solid because the crew never stops. You rest easier knowing that quiet sensing and measured responses are underway, shaping a scaffold that suits your days without asking for notice. You picture the bridge under you flexing just enough, the masonry tightening where traffic flows, gaps sealed before they widen. Next, you'll examine the spaces where two bones bargain between stability and motion. the joint designs, their cushions and ligaments, and how a sliding film turns friction into glide without wasting a step. You press your palm against a door hinge and feel metal glide with little sound. Your joints solve the same engineering problem every minute: how to trade stability for motion without scraping parts to dust. 4 ideas let you read any joint clearly: classification, stability, movement, and cartilage. Classification sorts the designs. Fibrous joints bind bones with dense connective tissue and allow minimal motion. Sutures knit skull bones. Their interdigitating edges distribute strain and permit skull growth early in life before fusing. Syndesmosis, like the distal tibiofibular joint, use a ligament or membrane to hold bones at a measured distance, allowing slight give that protects long levers from twisting forces. Gomphuses anchor teeth within sockets through a periodontal ligament that senses load and remodels with use. Cartilaginous joints come in 2 patterns. Synchondroses use hyaline cartilage between bones, classically the epiphyseal plate in growing long bones, and the first sternocostal joint, providing a firm, slightly compressible link. Symphyses place fibrocartilage between articular surfaces, as at the intervertebral discs and pubic symphyses. These joints absorb shock and allow limited collective motion across many segments. Synovial joints, the most mobile class, share a capsule lined by synovium, a sealed cavity with synovial fluid, and articular cartilage covering surfaces. Within that pattern, shapes specify the permitted directions. Plane joints, zygapophyseal facets, some carpals, slide. Hinge joints, elbow, interphalangeal, flex, and extend around a single axis. Pivot joints, proximal radioulnar, atlantoaxial, rotate. Condyloid joints, radiocarpal, permit flexion, extension, and abduction, adduction, with some circumduction. Saddle joints, first carpometacarpal, add a complementary curvature for a stable yet versatile thumb. Ball and socket joints, hip, shoulder, allow movement in multiple planes with rotation. Stability balances geometry with soft restraints. Bony congruence, the way surfaces fit, sets baseline security. The hip steep acetabulum embraces the femoral head, sharing load over a broad arc. The shoulder's shallow glenoid favors range, relying on other supports. The capsule, a fibrous sleeve, encloses the joint. Its thickness and orientation matter. Reinforcing ligaments, capsular thickenings or separate bands, limit excessive translation and rotation near end ranges. The ulnar collateral ligament resists elbow valgus. The iliofemoral ligament resists hip extension. Menisci and labra, wedges of fibrocartilage in the knee and rims in the shoulder and hip, deepen sockets, improve congruence, and redistribute stress. They also help seal fluid and maintain negative intra-articular pressure, a quiet suction that resists distraction. Muscles and tendons add dynamic stability, pressing surfaces together and steering motion towards safe paths. The rotator cuff centers the humeral head on the glenoid as larger movers create arcs. Proprioceptors and ligaments, capsule and muscles inform the nervous system. Reflex tuning increases stiffness when perturbations arrive. Even intra-articular fluid plays a role. Pressurization under load spreads contact and dampens sudden peaks. Movement has 2 layers, the obvious gross arcs and the hidden surface mechanics that make arcs smooth. Degrees of freedom count independent motions. A hinge has 1, a ball and socket has 3, for rotation plus translations constrained by soft tissues. Arthrokinematics describes how surfaces behave. Roll, glide, and spin combine to keep contact centered. The convex-concave rule summarizes a common pattern. When a convex surface moves on a concave one, roll and glide occur in opposite directions. When concave moves on convex, they occur in the same direction. These coupled micromotions prevent a tire-like roll off the edge of a small contact patch. Close packed positions maximize congruence and ligament tightness, knee in full extension, ankle dorsiflexed, making the joint more stable but less accommodating. Loose packed positions slacken restraints, permitting accessory glide that helps distribute synovial fluid and relieves focal stress. Chains of joints share tasks. In an open chain, the distal segment moves freely, kicking a ball, while in a closed chain the distal segment is fixed, rising from a chair, and forces transmit differently through stacked segments. Over many repetitions, joints adapt. Capsular fibers align with habitual strain, and neuromuscular patterns refine to reduce shear. Cartilage is the bearing surface that turns potential abrasion into glide. Articular cartilage is hyaline cartilage, specialized for load distribution and low friction. It is avascular and aneral. Nourishment arrives by diffusion from synovial fluid and to a lesser extent from subchondral bone. Chondrocytes, sparse, maintenance-focused cells, live within an extracellular matrix rich in type II collagen and proteoglycans. The architecture is zonal. The superficial zone has flattened cells and collagen fibers oriented parallel to the surface. It resists shear and houses lubricin, a glycoprotein critical for boundary lubrication. The middle transitional zone presents oblique fibers and high proteoglycan content, bridging shear to compression. The deep zone has perpendicular fibers anchored into a calcified cartilage layer, resisting compression and tying the soft layer to subchondral bone. Water constitutes most of the tissue by weight. Under load, fluid shifts within the matrix and can be exuded and reabsorbed, creating time-dependent behavior that spreads force like a well-oiled cushion, stiffening under impact and softening as load lingers. Lubrication modes vary with conditions. Boundary lubrication relies on surface molecules such as lubricin to reduce direct contact at slow speeds and high loads. Fluid film and elastohydrodynamic lubrication occur when motion and pressure draw synovial fluid between surfaces, generating a separating film that cuts friction dramatically. Fibrocartilage type I collagen-rich, tougher against tension, builds menisci, labra, and the annulus fibrosis of discs. It tolerates shear and tensile forces where hyaline alone would fail. Elastic cartilage with elastic fibers appears in flexible structures like the auricle but not in major load-bearing joints. When design, restraint, motion, and bearing cooperate, joints manage enormous repetition with quiet efficiency. The knee uses menisci to improve congruence between a rounded femoral condyle and a relatively flat tibial plateau. During flexion, the menisci deform and migrate, maintaining coverage and sharing load. The ankle's mortise grips the talus. As you dorsiflex, the wider anterior talar dome spreads the mortise, tightening the fit. In the spine, each motion segment combines a symphysis disc with paired synovial facets. Tiny motions across many levels yield graceful arcs, while the disc's nucleus pulposus, proteoglycan-rich gel, distributes compression and the annulus resists tension. A bedside scene clarifies stakes. After a twisting pivot on a planted foot, the knee swells over hours and feels unstable when descending stairs. A soft giving way suggests that ligaments and menisci, not just muscles, share blame. If the joint locks, if swelling is rapid and tense, if the knee cannot bear any weight, or if redness and fever accompany a hot, exquisitely tender joint, prompt professional evaluation is essential. Structural compromise and infection threaten function if not recognized quickly. Another example, a shoulder that slips out while reaching overhead, may reflect shallow bony congruence, coupled with lax capsule. Numbness over the lateral shoulder afterward raises concern for nearby nerve stretch, a finding that also needs timely expert assessment. A brief reflection. When you picture hinges, sockets, seals, and fluid films, the complexity feels orderly. Knowing which piece supplies what, calm you as you ask why a motion feels stiff or loose. You sense levers loading the hinges, tendons setting tension, and small arcs combining into reach and stride. Next, you will examine the pulling engines themselves, their fiber layouts, force transmission, lever trade-offs, and how different fibers favor endurance or bursts when you move without thinking. You clench your hand and feel force that seems simple, yet inside each contraction, countless engines align, fire, and transmit effort across invisible lines. Muscles are more than motors, they're architectures of precision that link design to performance. 4 core ideas guide you: architecture, contraction, levers, and fiber types. Architecture first. Skeletal muscle fibers are long cylindrical cells packed with myofibrils, chains of sarcomeres, the functional contractile units. Sarcomeres organize actin and myosin filaments between Z-lines. Their alignment creates the striations visible under a microscope. Force depends not only on fiber composition but on arrangement. Parallel or fusiform muscles like the biceps brachii have fibers aligned along the line of pull, allowing quick and wide range of motion but modest force. Pennate muscles such as the rectus femoris or deltoid arrange fibers at an angle to the tendon, increasing the number of fibers per cross-sectional area and thus force production, though at the cost of reduced shortening. Unipennate extensor digitorum longus, bipennate rectus femoris, and multipennate deltoid structures reflect local needs for power versus range. Tendons connect muscle to bone. Their collagen fibers are continuous with the muscle's connective tissue layers. Endomusium around fibers, perimusium around fascicles, and epimusium around the whole muscle. This continuous sheet transmits force smoothly across tissues. Fascial connections also spread tension between synergists, stabilizers, and even remote regions, a phenomenon called myofascial force transmission. The implication is quiet but powerful. Even when you isolate a muscle, its effort echoes across planes. Contraction is the heart of function. It begins with excitation. A motor neuron fires, releasing acetylcholine at the neuromuscular junction. This depolarizes the muscle membrane, triggering action potentials that travel along the sarcolemma and dive into the T-tubule system. Inside, voltage-sensitive receptors, dihydropyridine receptors, interact with ryanodine receptors on the sarcoplasmic reticulum, releasing calcium into the cytoplasm. Calcium binds to troponin C, shifting tropomyosin off actin's myosin binding sites. Myosin heads, already charged with ATP, bind actin and undergo a power stroke, pulling actin toward the sarcomere center. ATP binds again, detaching myosin, and the cycle repeats as long as calcium and ATP remain. When stimulation ceases, calcium is pumped back into the sarcoplasmic reticulum by circopumps, and contraction ends. The sequence is tightly regulated. Even small delays or leaks alter function. Isometric contraction holds tension without changing muscle length. Concentric contraction shortens the muscle while generating force, as in lifting a weight. Eccentric contraction controls lengthening under load, lowering that weight gently and often produces more force with fewer motor units. Eccentric loads also stress tendons and connective tissues more. Adaptation here helps prevent injury. Motor units, one motor neuron and all the fibers it innervates are the basic control units. Small units allow fine control, ocular muscles. Large ones favor strength, gastrocnemius. Recruitment follows the size principle. Small fatigue-resistant units activate first. As demand increases, larger, more powerful units join. This graded control economizes energy and preserves endurance. Muscles pull on bones through levers, amplifying motion or force. A lever has three parts: the effort, muscle force, the resistance, load, and the fulcrum, joint. In a first-class lever, the fulcrum sits between effort and load, e.g. atlanto-occipital joint, where posterior neck muscles counterbalance head weight. In a second-class lever, the load lies between effort and fulcrum, e.g. standing on tiptoe, calf muscles lift the heel while the ball of the foot serves as the fulcrum. In a third-class lever, the most common in the body, effort lies between fulcrum and load, e.g. biceps flexing the elbow. This arrangement favors speed and range over force, explaining why human motion feels fluid but not mechanically strong in isolated effort. Tendon insertion points affect leverage. A longer moment arm, distance from joint axis to line of force, increases torque but reduces speed. A shorter arm increases speed but requires more force. The musculoskeletal system negotiates these trade-offs through evolutionary optimization. Fiber types explain performance profiles. Type 1 fibers are slow twitch, oxidative, and fatigue-resistant. They have high mitochondrial density, abundant myoglobin, giving a red color, and depend on aerobic metabolism. Postural muscles like the soleus rely heavily on these fibers for sustained activity. Type 2 fibers subdivide into I-Ta-A and Ta-X. Type 2A fibers are fast-twitch, oxidative, glycolytic. They combine decent power with some endurance. Type 2X fibers are fast-twitch, glycolytic. They produce rapid, powerful contractions but fatigue quickly. They have fewer mitochondria, rely on anaerobic metabolism, and appear paler. Training shifts fiber characteristics. Endurance training increases mitochondrial density and oxidative enzymes, improving fatigue resistance. Resistance training enlarges fiber diameter and increases glycolytic capacity, especially in type 2 fibers. The nervous system also adapts. Motor unit synchronization and firing rates improve with use. Aging and disuse alter the mix. Type 2 fibers tend to atrophy faster, leading to reduced power and increased fall risk in older adults. Muscle plasticity, its ability to change with loading, makes it a reliable early responder to lifestyle changes. These design principles converge in familiar actions. A sprinter's explosive start reflects rapid recruitment of type 2 fibers in hip extensors and plantar flexors, driving power through third-class levers. A marathoner's slow rhythm depends on type 1 fibers, coordinated and fatigue-resistant patterns. Climbing stairs engages eccentric contraction of quadriceps to lower the body with control, distributing tension through fascia, tendons, and motor units. Throwing a ball links trunk rotation to shoulder and wrist through fascial planes, showing how even distant muscles can augment effort. In rehabilitation, understanding these principles informs why training type, speed, and volume matter. Each targets different systems, each adapts uniquely. At the bedside, a patient with difficulty rising from a chair shows proximal muscle weakness. You observe hip and shoulder girdle involvement. If strength declines rapidly, if fasciculations or altered reflexes appear, or if the weakness is asymmetric and progressive, this constellation warrants prompt professional evaluation, as neuromuscular disorders must be distinguished from fatigue or disuse. In another case, after an eccentric heavy workout, delayed onset muscle soreness appears, tenderness without swelling or bruising, stiffness that fades over days. The fibers have adapted microdamage and will remodel stronger. But if swelling is excessive, urine darkens, or pain worsens abruptly, these could signal more serious muscle breakdown needing expert care. A brief reflection. Understanding how muscle fibers align, fire, and fuse effort across tissues makes motion less mysterious. You see that even rest involves low-level orchestration, stillness has structure. You imagine cords tensing in harmony, sheets of fibers pulling with just enough force, energy converted to motion without waste. Next, you'll explore the electrical signaling that tells these fibers when to fire, how neurons communicate, how reflexes shield you before thought, and how complex decisions arise from simple circuits. You touch a warm surface and withdraw your hand before thinking. The signal took less than a second, but behind that motion lies a network that spans from skin to spinal cord and back. Nervous tissue isn't just fast, it's hierarchical, precise, and deeply conserved. 4 concepts guide your understanding: neurons, synapses, reflexes, and divisions. Neurons are the functional units of the nervous system. Each has a cell body, soma, dendrites that receive input, and a single axon that conducts output. Dendrites branch near the soma, increasing the surface area for synaptic contact. The axon can stretch meters in length in large animals and often branches at its terminus to contact multiple targets. Information within the neuron travels via electrical impulses called action potentials, which arise when voltage-gated ion channels open in sequence along the axon membrane. Resting membrane potential, typically around 570 mV, is maintained by the sodium-potassium ATPase pump and selective ion permeability. When a threshold is reached, sodium rushes in, depolarizing the membrane. Potassium then exits, repolarizing it. This traveling wave doesn't fade because it's regenerated along the axon. Axons are often wrapped in myelin, a lipid-rich sheath that insulates and accelerates conduction by forcing impulses to jump between gaps called nodes of Ranvier, a process called saltatory conduction. In the central nervous system (CNS), oligodendrocytes provide myelin. In the peripheral nervous system (PNS), Schwann cells do. Myelinated fibers conduct signals more rapidly and with greater fidelity than unmyelinated ones. Neurons do not divide but can regenerate axons under certain conditions, especially in the PNS where guidance cues and supportive cells facilitate regrowth. The shape of a neuron, unipolar, bipolar, multipolar, reflects its role. Sensory neurons often have a pseudo-unipolar form, allowing quick signal routing from periphery to spinal cord. Motor neurons are multipolar, with long axons reaching target muscles. Synapses are the junctions where neurons communicate. Most are chemical. The presynaptic terminal releases neurotransmitters into the synaptic cleft. The postsynaptic membrane bears receptors that bind these molecules, triggering changes in ion permeability and initiating a new electrical impulse. Synaptic transmission is tightly regulated. Calcium influx into the presynaptic terminal triggers vesicle fusion. Neurotransmitter clearance involves reuptake, diffusion, or enzymatic degradation. Different neurotransmitters serve distinct roles. Glutamate is the primary excitatory transmitter in the CNS. GABA and glycine are inhibitory. In the PNS, acetylcholine activates skeletal muscle at the neuromuscular junction and mediates parasympathetic functions. Norepinephrine governs much of the sympathetic system. Electrical synapses, by contrast, use gap junctions, direct cytoplasmic bridges that allow ions and small molecules to pass between cells. These connections are fast and bidirectional, found in reflex pathways and areas requiring synchronization, such as certain brainstem nuclei or cardiac conduction tissue. The speed of electrical synapses favors reflex arcs and rhythmic systems. The flexibility of chemical synapses enables learning, modulation, and integration. Reflexes demonstrate the nervous system's ability to act before conscious thought. A reflex arc includes a sensory receptor, an afferent incoming neuron, a central integration center, an efferent outgoing neuron, and an effector, usually muscle. The simplest reflex, the stretch reflex, involves a monosynaptic arc. When a muscle spindle senses stretch, it sends a signal via a sensory neuron directly to a motor neuron in the spinal cord, triggering contraction of the same muscle. This is the basis of the patellar tendon knee-jerk reflex. The spindle itself contains intrafusal fibers and sensory endings that detect length changes. Gamma motor neurons adjust spindle sensitivity. More complex reflexes include interneurons, allowing inhibition or coordination across muscles. In the flexor withdrawal reflex, painful stimuli activate afferent fibers that excite interneurons, which in turn stimulate motor neurons to withdraw the limb and inhibit antagonists. In crossed extensor reflexes, contralateral muscles engage to support posture during withdrawal. These pathways are hardwired but modifiable. Central pattern generators in the spinal cord coordinate rhythmic activities like walking, even without cortical input, as long as sensory feedback is intact. Brainstem reflexes, like the pupillary light reflex, also follow arc logic but integrate cranial nerves. Nervous system divisions clarify structure and function. Structurally, the CNS includes the brain and spinal cord. The PNS includes cranial nerves, spinal nerves, and their branches. Functionally, you divide the system into somatic and autonomic. The somatic system governs voluntary control of skeletal muscles and conscious sensory perception. The autonomic system regulates involuntary functions, heart rate, digestion, pupil diameter, and has three components: sympathetic, parasympathetic, and enteric. The sympathetic system prepares the body for action. Its preganglionic neurons arise from thoracic and lumbar spinal segments, exit via ventral roots, and synapse and ganglia located near the vertebral column, sympathetic chain, or in prevertebral ganglia. Postganglionic fibers are long and reach target organs. Acetylcholine is the preganglionic transmitter. Norepinephrine is usually postganglionic except at sweat glands, which use acetylcholine. Sympathetic effects include pupil dilation, bronchodilation, increased heart rate, and vasoconstriction in non-essential regions. The parasympathetic system promotes rest and digestion. Its preganglionic neurons arise from brainstem nuclei and sacral spinal cord segments. These neurons synapse and ganglia close to or within the target organs, and postganglionic fibers are short. Both pre- and postganglionic neurons use acetylcholine. Parasympathetic activity constricts pupils, slows the heart, stimulates digestion, and promotes glandular secretions. The vagus nerve, cranial nerve X, supplies most thoracic and abdominal organs with parasympathetic fibers. The enteric nervous system is semi-autonomous, embedded in the walls of the gastrointestinal tract. It contains sensory, motor, and interneurons organized into plexuses, myenteric and submucosal, and can coordinate peristalsis and secretion independently of the CNS, though modulated by sympathetic and parasympathetic input. Together, these divisions enable fluid coordination. When you stand suddenly, baroreceptors trigger a sympathetic increase in vascular tone to maintain blood pressure. When you eat, parasympathetic pathways activate digestive motility and enzyme secretion. When you feel threatened, the sympathetic system primes muscles and suppresses non-essential activity. At the bedside, a person with numbness in a dermatomal pattern, say over the lateral thigh or between the great toe and second toe, signals possible nerve root compression. If weakness and altered reflexes accompany the sensory loss, a lower motor neuron lesion is likely. Conversely, diffuse numbness with normal strength may reflect peripheral neuropathy. When symptoms appear abruptly, worsen rapidly, or involve bowel or bladder control, urgent professional evaluation is necessary to rule out compressive or inflammatory processes that could threaten function or life. A brief reflection in the time it takes to decide to move, 100 arcs have already fired, adjusted, and returned. The nervous system's silence is its greatest feat. You hear the signal crossing gaps, the impulse carried down a living wire, the response shaping motion before thought catches up. Now you'll journey into the brain itself, 4 regions that sense, select, relay, and refine, each shaping awareness and motion in ways both clear and invisible. You open your eyes in a dim room and orient yourself without thinking. Behind that instant clarity, 4 brain regions coordinate perception, choice, coordination, and correction. Their cooperation shapes everything from sensation to balance. The cortex, basal ganglia, thalamus, and cerebellum form a functional quartet whose silent roles define your every waking act. The cerebral cortex is the brain's outer layer of gray matter, organized into folds, gerry, grooves, sulci that increase surface area. It is divided into lobes by anatomical landmarks and functional zones by neural networks. The frontal lobe governs planning, voluntary movement, and speech production. Its prefrontal cortex handles executive function and social behavior, while the primary motor cortex, precentral gyrus, sends commands to skeletal muscles. The parietal lobe integrates sensory information, touch, position, and spatial awareness via the primary somatosensory cortex, postcentral gyrus. The occipital lobe processes visual input. The temporal lobe manages hearing, language comprehension, and memory. Each hemisphere exhibits specialization. Language is typically lateralized to the left. Visuospatial tasks often favor the right. Within the cortex, sensory areas receive and map specific inputs, somatopy, retinotopy, motor areas direct outputs, and association areas synthesize context, emotion, and relevance. These zones communicate via short and long axons forming white matter tracts. Association fibers connect within a hemisphere. Commissural fibers like the corpus callosum link both sides, and projection fibers descend to subcortical and spinal structures. Thought emerges not from isolated zones but from dense reciprocal circuits where even a brief sensation travels through layered filters before rising to conscious perception. Beneath the cortex lie the basal ganglia, a group of interconnected nuclei, including the caudate nucleus, putamen, globus pallidus, subthalamic nucleus, and substantia nigra. These deep structures do not initiate movement but modulate it, selecting useful actions, suppressing competing ones, and smoothing transitions. The system loops through the cortex, basal ganglia, thalamus, and back. In the direct pathway, cortical input excites striatal neurons that inhibit the globus pallidus internus, which normally suppresses the thalamus. This disinhibition allows thalamic activation of motor areas. In the indirect pathway, other striatal neurons inhibit the globus pallidus externus, which reduces its inhibition of the subthalamic nucleus. This nucleus then excites the globus pallidus internus, increasing thalamic suppression. Dopamine, released by the substantia nigra pars compacta, modulates both paths, enhancing the direct and inhibiting the indirect, thus promoting movement. The balance between these streams refines motion, focus, and decision-making. When these circuits falter, patterns emerge. Parkinson's disease reflects degeneration of dopaminergic neurons, leading to bradykinesia, rigidity, resting tremor, and postural instability. Huntington's disease involves degeneration of striatal neurons, resulting in chorea and behavioral changes. These are not purely motor disorders. They echo into mood, attention, and learning, showing the basal ganglia's reach beyond muscle. The thalamus sits atop the brainstem and acts as the brain's relay station. Nearly all sensory information except olfaction passes through the thalamus before reaching cortex. It contains multiple nuclei, each with specific inputs and targets. The lateral geniculate nucleus relays visual information from the optic tract to the primary visual cortex. The medial geniculate nucleus handles auditory signals en route to the auditory cortex. Ventral posterior nuclei transmit somatic sensations to the somatosensory cortex. Other nuclei coordinate motor signals from cerebellum and basal ganglia to cortex or integrate limbic emotional input. Importantly, the thalamus is not passive. It filters, amplifies, and modulates signals, controlling attention and gating what reaches consciousness. Thalamic neurons exhibit burst and tonic firing modes, influencing cortical arousal and sleep states. The reticular nucleus, a thin shell of GABAergic neurons surrounding the thalamus, helps regulate this filtering process. Damage here by stroke, trauma, or infection can produce profound sensory loss, pain syndromes, or altered consciousness. The thalamus is a gatekeeper. When it fails, signals misroute or vanish entirely. Behind and below, the cerebellum sits in the posterior cranial fossa, tucked under the occipital lobes. Though only about 10% of brain volume, it houses over half the brain's neurons, organized into a layered cortex over white matter tracts and deep nuclei. The cerebellum's role is to coordinate timing, accuracy, and balance. It compares intended movement from cortex with actual movement via proprioceptive input and issues corrections in real time. It receives inputs through 3 cerebellar peduncles. The superior connects to the midbrain and conveys output. The middle carries cortical input via pontine nuclei. The inferior carries spinal and vestibular input. Output arises from deep cerebellar nuclei, dentate, emboliform, globose, fastigial, and loops back to motor areas via the thalamus. Functionally, the cerebellum is divided into 3 zones. The vestibulocerebellum, flocculonodular lobe, governs balance and eye movements. The spinocerebellum, vermis and intermediate hemisphere, refines trunk and limb movements. The cerebrocerebellum, lateral hemispheres, coordinates planning and complex movement. When cerebellar output falters, motion becomes irregular, dysmetria, overshoot, intention tremor worsening as a target is approached, and ataxia, impaired coordination emerge. Speech may slur, gaze may drift, and stance may stagger, not from weakness but from mistiming. Because the cerebellum calibrates automatic patterns, dysfunction feels disorienting despite preserved strength. Together, these 4 regions form nested loops. The cortex decides and commands, the basal ganglia filter options, the thalamus gates and routes, the cerebellum calibrates and corrects. Their cooperation enables fluidity, walking while conversing, writing while thinking, catching a ball reflexively. Disruption in any node alters the whole pattern. Stroke in the internal capsule, a dense tract passing between basal ganglia and thalamus, can interrupt motor and sensory pathways simultaneously. Lesions in the thalamus distort sensation. Dysfunction in the cerebellum scrambles coordination despite normal tone. At the bedside, a person with sudden hemiparesis, altered speech, or loss of sensation on one side suggests cortical or subcortical injury. If symptoms fluctuate rapidly or involve multiple systems, motor, sensory, visual, language, thalamic or basal ganglia involvement may be present. If coordination fails but strength and sensation remain intact, cerebellar dysfunction is likely. When symptoms onset abruptly, worsen, or include altered consciousness or seizure, urgent expert evaluation is required. Timing can preserve function. A brief reflection. Inside each motion, a whisper from 4 regions shapes whether it begins, continues, adjusts, or ends. To move well is to think in motion. You feel plans selected, filtered, routed, then refined, each layer checking the last, the result silent and smooth. Next, you'll travel through 12 cables that carry vision, taste, balance, expression, and more. Cranial nerves whose paths and functions connect brain to world in finely mapped lines. You smile, swallow, smell, and hear, all through 12 paired conduits that exit the brain and branch like wires to sense and control the head and neck. These are the cranial nerves. Each follows a defined route and serves specific functions, with some purely sensory, others purely motor, and several mixed. The layout is fixed, but the diversity of effects from eye movement to heart rate emerges from their combined actions. Understanding their functions and paths clarifies how localized symptoms point precisely to which nerve is involved. Cranial nerves are numbered, all to 12 in order of their emergence from the brain, rostral front to caudal back. Each has a name that reflects its primary role. The first 2, olfactory and optic, are technically CNS tracts. The rest emerge from the brainstem and are true peripheral nerves. Cranial nervi, the olfactory nerve, mediates smell. Olfactory receptor neurons in the nasal mucosa send axons through the cribriform plate of the ethmoid bone to synapse in the olfactory bulb. From there, second-order neurons project to the olfactory cortex and limbic areas. Unlike other senses, smell bypasses the thalamus initially. Because these neurons regenerate, they offer a rare example of ongoing neurogenesis. Loss of smell, anosmia, can result from nasal blockage, trauma to the cribriform plate, or neurodegeneration. Cranial nerve 2, the optic nerve, carries visual input from the retina to the brain. Retinal ganglion cells converge to form the optic nerve, which passes through the optic canal to reach the optic chiasm, where fibers from the nasal retina cross to the opposite side. Beyond this, the optic tracts project to the lateral geniculate nucleus of the thalamus, then to the primary visual cortex via the optic radiations. The result is a precisely mapped visual field. Lesions at different points along this path create distinct visual deficits. Loss in one eye suggests optic nerve damage. Bitemporal hemianopia, loss of peripheral vision, suggests chiasmal compression. Homonymous hemianopia, loss of the same side in both eyes, implies tract or cortical involvement. Cranial nerves 3, IV and CI, oculomotor, trochlear, and abducens, control eye movements. The oculomotor nerves 3 innervates most extraocular muscles, superior, medial, and inferior rectus, inferior oblique. The levator palpebrae lifts the eyelid and provides parasympathetic fibers to the pupil, constrictor pupillae, and lens, ciliary muscle. A lesion causes ptosis, outward deviation due to unopposed lateral rectus and superior oblique, and a dilated non-reactive pupil. The trochlear nerve 4 innervates the superior oblique, which depresses and entorts the eye. Damage causes vertical diplopia, especially when looking downstairs. The abducens nerve 6 controls the lateral rectus, abducting the eye. Dysfunction causes medial deviation and horizontal diplopia. Because CI has a long intracranial course, it is vulnerable to increased intracranial pressure. Cranial nerve V, the trigeminal nerve, is the main sensory nerve of the face and provides motor innervation to the muscles of mastication. It has 3 branches: ophthalmic V1, maxillary V2, and mandibular V3. V1 and V2 are purely sensory, covering the forehead and midface respectively. V3 carries both sensory fibers, jaw, lower face, and motor fibers to mastere, temporalis, and pterygoid muscles. Corneal reflex testing assesses V1, afferent limb, while jaw clench tests V3. Trigeminal neuralgia, brief. Stabbing facial pain in V2 or V3 distribution. Reflex nerve irritation, sometimes without a clear structural cause. Cranial nerve 7, the facial nerve, controls facial expression muscles and conveys taste from the anterior 2/3 of the tongue. It also provides parasympathetic fibers to the lacrimal and salivary glands, except the parotid. The facial nerve emerges from the pons, enters the internal acoustic meatus, traverses the facial canal and the temporal bone, and exits the skull via the stylomastoid foramen. Because it bends sharply within bone, it is vulnerable to inflammation or compression. A lower motor neuron lesion, e.g. Bell's palsy, causes weakness of the entire ipsilateral face, including forehead. A central upper motor neuron lesion spares the forehead due to bilateral cortical innervation. Cranial nerve 8, the vestibulocochlear nerve, transmits hearing and balance. It divides into cochlear and vestibular branches. The cochlear portion carries signals from hair cells in the organ of Corti to the auditory cortex. The vestibular portion detects head position and movement via semicircular canals and otolith organs, projecting to brainstem nuclei and the cerebellum. Lesions can cause hearing loss, vertigo, nystagmus, and balance disturbances. Acoustic neuromas, benign tumors of the vestibular nerve, may present first with unilateral hearing loss. Cranial nerves I-Ax and X, glossopharyngeal and vagus, carry mixed fibers and support overlapping functions in swallowing, taste, visceral sensation, and autonomic control. The glossopharyngeal nerve I-X supplies taste to the posterior third of the tongue, sensation to the pharynx and middle ear, and motor fibers to one pharyngeal muscle, stylopharyngeus. It also carries visceral afferents from the carotid body and sinus, informing blood pressure regulation. The vagus nerve X, more extensive, innervates most pharyngeal and laryngeal muscles, conveys visceral sensation from thoracic and abdominal organs, and carries parasympathetic fibers to the heart, lungs, and gut. Injury can cause hoarseness, difficulty swallowing, or loss of gag reflex. The gag reflex uses I-Ax as afferent and X as efferent limbs. Cranial nerve XI, the spinal accessory nerve, innervates the sternocleidomastoid and trapezius muscles. It arises from cervical spinal cord segments, ascends into the skull through the foramen magnum, and exits via the jugular foramen. Weakness affects head turning and shoulder shrugging. A lesion may follow neck surgery or trauma and results in shoulder droop and impaired overhead arm movement due to trapezius dysfunction. Cranial nerve 12. The hypoglossal nerve controls intrinsic and extrinsic tongue muscles. It exits the skull through the hypoglossal canal and innervates the tongue from below. Damage causes tongue deviation toward the lesion side on protrusion and may result from stroke, trauma, or mass effect. Bilateral lesions impair swallowing and speech articulation significantly. Understanding cranial nerve testing translates symptoms into locations. For example, facial weakness with hearing loss suggests a lesion at the internal acoustic meatus, possibly compressing both 7 and 8. Dysphagia and hoarseness with reduced gag reflex point to 9 and X involvement. A medial medullary stroke affecting 12 results in tongue deviation without facial weakness. At the bedside, someone with sudden onset diplopia, facial asymmetry, or unilateral sensory loss over the face may be expressing cranial nerve dysfunction. If multiple nerves are involved, especially with other brainstem signs, vertigo, dysarthria, ataxia, the concern for brainstem stroke or tumor rises. If facial weakness develops gradually or after a viral illness, isolated inflammation may be the cause. Any involvement of vision, swallowing, or balance should prompt timely expert evaluation, as early intervention preserves function. A brief reflection. 12 threads weave your face, senses, and voice into your experience. Knowing their routes gives form to symptoms and precision to concern. You see cables exit the brainstem, cross bone and muscle, and animate your expression, perception, and control with economy. Next, you'll descend through the spinal cord, white tracts, gray horns, reflex arcs, and protective linings that connect brain to body with relentless fidelity. You trace your fingers down your back and imagine a silent column conducting thoughts into movement, sensation into awareness. That column, the spinal cord, organizes control and feedback in layers of white and gray, with circuits that refine reflexes, coordinate limbs, and encode regions of the body in an orderly map. 4 concepts clarify this central bridge: tracts, dermatomes, reflex arcs, and mendes. The spinal cord is a cylindrical structure housed within the vertebral canal, extending from the foramen magnum to approximately the level of the L1-L2 vertebrae in adults. Below that, the cauda equina, nerve roots trailing in cerebrospinal fluid, continues to fill the canal. The cord is segmented, with 31 pairs of spinal nerves arising from its lateral borders, 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. Each segment gives rise to a dorsal posterior root carrying sensory fibers and a ventral anterior root carrying motor fibers. These roots merge to form mixed spinal nerves, which then branch into dorsal and ventral rami, serving the back and front of the body respectively. Within the cord, white matter surrounds a central butterfly-shaped gray matter core. White matter contains ascending and descending tracts, myelinated axons organized by function and destination. Ascending tracts carry sensory information from periphery to brain. The dorsal columns fasciculus gracilis and cuneatus transmit fine touch, vibration, and proprioception ipsilaterally. They decussate cross in the medulla. The spinothalamic tracts carry pain and temperature. These fibers cross in the spinal cord shortly after entry, then ascend contralaterally. The spinocerebellar tracts carry proprioceptive information to the cerebellum for coordination, some of which remain ipsilateral. Descending tracts control voluntary and involuntary motor output. The corticospinal tracts originate in the motor cortex and descend through the internal capsule, brainstem, and spinal cord. The lateral corticospinal tract decussates in the medullary pyramids and controls limb muscles. The anterior corticospinal tract remains mostly ipsilateral and modulates axial muscles. Other tracts, such as the rubrospinal, vestibulospinal, and reticulospinal pathways, coordinate posture and reflex responses. Damage to descending tracts leads to characteristic findings: weakness, spasticity, hyperreflexia, and loss of fine motor control below the lesion if upper motor neurons are affected. The gray matter of the spinal cord is divided into dorsal, ventral, and lateral horns. The dorsal horn receives incoming sensory information. Interneurons here process pain, temperature, and crude touch before sending signals to higher centers. The ventral horn contains lower motor neurons that directly innervate skeletal muscle. The size of the ventral horn varies by segment. It is largest in cervical and lumbar enlargements, where limb motor neurons are concentrated. The lateral horn, present in thoracic and upper lumbar segments, contains preganglionic sympathetic neurons of the autonomic nervous system. These neurons exit via ventral roots, enter the sympathetic chain, and either synapse there or travel to prevertebral ganglia. Dermatomes map the skin's sensory supply to spinal nerve roots. Each dermatome is a strip of skin innervated by a specific spinal nerve. This map forms a stacked pattern from head to toe. For instance, C5 covers the lateral upper arm, T4 lies at the level of the nipples, T10 surrounds the umbilicus, L4 extends to the medial lower leg. Dermatomal maps help localize lesions. A herniated disc compressing the L5 root may cause numbness on the dorsum of the foot and weakness in big toe extension. However, overlap between adjacent dermatomes ensures that complete sensory loss rarely results from damage to a single root. Reflex arcs within the spinal cord create rapid, involuntary responses to stimuli. The stretch reflex, such as the patellar reflex, tests integrity of the monosynaptic connection between a muscle spindle afferent and a motor neuron. Tapping the patellar tendon stretches the quadriceps, activating muscle spindles that send afferent signals via the femoral nerve to the L4 spinal cord level. The motor neuron then fires, contracting the quadriceps and producing knee extension. The Achilles reflex, S1, biceps reflex, C5, C6, and triceps reflex, C7, work similarly. Absence or exaggeration of reflexes suggests lower or upper motor neuron lesions respectively. Other reflexes involve interneurons, such as the withdrawal reflex activated by painful stimuli and crossed extensor reflexes that support posture during rapid withdrawal. Protecting the spinal cord are three meninxes: dura mater, arachnoid matter, and pia mater. The dura mater is a tough outer sheath that forms the thecal sac and extends to S2. The arachnoid matter beneath it is a delicate membrane that spans across the subarachnoid space, which contains cerebrospinal fluid (CSF). This space cushions the cord, facilitates nutrient transport, and permits safe needle access for lumbar puncture below L2. The pia mater lies directly on the cord surface, sending extensions called denticulate ligaments that anchor the cord laterally to the dura. Inferiorly, the pia continues as the filum terminale, anchoring the cord to the coccyx. Disruption to these protective layers from trauma, infection, or malignancy can threaten spinal integrity. Inflammation, meningitis, irritates the coverings, while hemorrhage or compression from mass lesions distorts nearby neural structures. At the bedside, a patient with sudden loss of motor and sensory function below a spinal level raises immediate concern for spinal cord compression. If bladder control is lost, if saddle anesthesia appears, or if reflexes vanish, then return exaggerated, urgent expert evaluation is necessary. A dermatomal band of numbness, progressive limb weakness, or asymmetric reflex changes can point to precise levels. For example, a C6 lesion may produce wrist extension weakness and numbness in the thumb. In traumatic injury, sparing of sacral sensation, perianal pinprick suggests incomplete cord damage, which has prognostic value. A more gradual onset may reflect tumor, abscess, or vascular malformation. A brief reflection, knowing where the fibers run and where the nerves branch, builds quiet confidence, each symptom a signpost to a specific tract or route. You picture white columns conducting speed, gray horns integrating response, and a durable sheath allowing motion without compromise. Next, you'll study the automatic side of this system, how the body regulates itself through quiet signals that speed, slow, and synchronize without conscious command. Your heart beats faster in danger, your pupils widen, your gut slows, yet you made no decision. These adjustments come from a network beneath awareness, the autonomic nervous system ANS. Through a blend of chemical precision and layered design, it balances internal states. 4 principles guide its quiet control: sympathetic, parasympathetic, enteric, and receptors. The sympathetic division prepares the body for activity. Its preganglionic neurons originate in the lateral horns of thoracic and upper lumbar spinal cord segments, T1 to L2. These neurons exit via ventral roots, briefly join spinal nerves, then branch into white rami communicanta to enter the sympathetic chain, paired ganglia flanking the vertebral column. From there, they can synapse at the same level, ascend or descend to other ganglia, or pass through to synapse in prevertebral ganglia, such as the celiac superior mesenteric or inferior mesenteric ganglia. Postganglionic neurons are long and project to target organs, heart, lungs, vessels, sweat glands, and more. The sympathetic system acts broadly. It increases heart rate and force of contraction via beta-1 adrenergic receptors, dilates bronchi through beta-2 receptors, constricts peripheral vessels via alpha-1 receptors, dilates pupils mydriasis by contracting radial muscles, inhibits gastrointestinal motility, and stimulates sweat production, eccrine glands using acetylcholine unusually. The adrenal medulla functions as a modified sympathetic ganglion. Preganglionic neurons stimulate chromaffin cells to release epinephrine and norepinephrine directly into the bloodstream, amplifying systemic effects. This mechanism ensures rapid mobilization, redirecting blood, releasing glucose, and optimizing oxygen delivery. The effect is fast but not chaotic. It reflects a prepared shift into high alert function. The parasympathetic division conserves and restores energy. Its preganglionic neurons arise from cranial nerves 3, 7, 9, and X, and from sacral spinal segments S2 to S4. These neurons have long axons that travel to or near their target organs, where they synapse in small terminal ganglia. Postganglionic fibers are short and precisely target specific effectors. The vagus nerve, cranial nerve X, is dominant, supplying parasympathetic fibers to most thoracic and abdominal organs. The sacral outflow serves pelvic organs. Parasympathetic activity slows heart rate, constricts pupils, meiosis, stimulates salivation, enhances gastrointestinal motility and secretion, contracts the bladder, and supports sexual arousal. Acetylcholine is the neurotransmitter for both pre- and postganglionic fibers. Effects are localized and deliberate, more like dial settings than switches. Because its outflow lacks a chain like the sympathetic trunk, parasympathetic tone reflects discrete circuits rather than mass activation. The result is a baseline of rest, repair, and nutrient absorption, a default mode the body favors in safety. The enteric nervous system, embedded in the walls of the gastrointestinal tract, operates semi-independently. It contains millions of neurons, more than the spinal cord, organized into two main plexuses. The myenteric Auerbach's plexus lies between the longitudinal and circular muscle layers and controls motility. The submucosal Meissner's plexus, located in the submucosa, regulates secretion and blood flow. These neurons receive sensory input from gut mechanoreceptors and chemoreceptors, integrate signals, and modulate motor and secretory responses. While the enteric system communicates with both sympathetic and parasympathetic divisions, it can generate rhythmic patterns such as peristalsis without central input. This autonomy allows it to continue digestive processes even after spinal cord injury, albeit with some modulation loss. Receptors determine response. Adrenergic receptors respond to norepinephrine and epinephrine. Alpha-1 receptors mediate vasoconstriction and pupil dilation. Alpha-2 receptors, primarily presynaptic, inhibit further neurotransmitter release. Beta-1 receptors increase heart rate and contractility. Beta-2 receptors mediate smooth muscle relaxation in bronchi, vessels, and uterus. Beta-3 receptors influence adipose tissue metabolism. Cholinergic receptors bind acetylcholine. Nicotinic receptors appear at autonomic ganglia and neuromuscular junctions. They are ligand-gated ion channels that depolarize target cells. Muscarinic receptors found on parasympathetic targets are G-protein coupled and vary by subtype. M2 slows the heart, M3 stimulates glandular secretion and smooth muscle contraction in the gut and bladder. These receptor types allow specificity. For instance, beta-2 receptors dilate bronchi, while alpha-1 receptors constrict peripheral arterioles. This is why a single neurotransmitter can produce opposing effects in different tissues. Drugs that mimic or block these receptors, agonists and antagonists, form the basis of many clinical treatments, from beta blockers, slowing the heart, to muscarinic antagonists easing bladder spasm. The ANS adapts to context through reflex loops. Baroreceptors in the carotid sinus and aortic arch detect blood pressure changes and relay signals via cranial nerves INs and X to the solitary nucleus in the medulla. This center adjusts sympathetic and parasympathetic tone to stabilize pressure. During standing, sympathetic tone increases to maintain perfusion to the brain. When lying down, tone relaxes. Other reflexes modulate bladder emptying, pupillary response to light, and gastrointestinal peristalsis. Higher centers, including the hypothalamus and limbic system, modulate autonomic output during emotion, fear, or anticipation, linking physiological state to mental context. At the bedside, a person with dry mouth, lightheadedness on standing, constipation, or pupil abnormalities may be expressing autonomic dysfunction. If orthostatic hypotension develops with normal heart rate, parasympathetic input may be intact, but sympathetic vasoconstriction impaired. In conditions like diabetes, small autonomic fibers may degenerate, leading to silent hypoglycemia, impaired sweating, and altered gut motility. In severe cases, widespread autonomic failure can cause life-threatening instability. Prompt expert evaluation becomes essential when multiple systems are involved, especially if heart rate, blood pressure, temperature control, or pupillary responses change abruptly. A brief reflection. The body's quiet adjustments, faster pulse, slower gut, widened pupil, occur without request. Understanding these pathways makes the invisible feel ordered. You notice how calm holds one setting, alarm another, and recovery yet a third, all modulated silently through branching fibers. Next, you'll enter the special senses, how eyes, ears, nose, and balance organs convert light, sound, motion, and molecules into neural language you can perceive. You open your eyes to a dim room, hear distant footsteps, smell warm food, and remain upright, all before a word is spoken. These sensations reach you through specialized portals tuned to light, vibration, chemical signals, and motion. 4 senses, vision, hearing, balance, and smell, demonstrate how external stimuli become electrical codes interpreted as experience. Vision begins in the retina, where light passes through transparent layers before reaching photoreceptors. Rods detect low light contrast and motion. Cones discriminate color and fine detail in brighter conditions. Phototransduction begins when photons activate visual pigments, rhodopsin in rods, photopsins in cones, causing conformational changes that trigger a G protein cascade. This cascade closes cyclic GMP-gated sodium channels, hyperpolarizing the cell and reducing glutamate release. Downstream bipolar and ganglion cells process this change, integrating spatial and temporal contrast. Horizontal and amacrine cells refine the signal through lateral inhibition, sharpening edges and motion detection. Ganglion cell axons converge at the optic disc to form the optic nerve. After passing through the optic chiasm where nasal fibers cross, the pathway continues as optic tracts to the lateral geniculate nucleus, LGN, of the thalamus. From there, optic radiations fan out to the primary visual cortex, V1, in the occipital lobe. The superior visual field projects to the inferior retina and vice versa, maintaining precise retinotopy. Additional projections reach the superior colliculus, eye movement coordination, and protectal area pupillary reflex. This circuit allows you to locate, track, and interpret visual stimuli in milliseconds. Hearing transforms air pressure waves into electrical signals. Sound enters the external auditory canal, vibrates the tympanic membrane, and transfers through the ossicles, malleus, incus stapes to the oval window. This mechanical leverage amplifies sound as it enters the cochlea, a fluid-filled spiral within the temporal bone. Movement of the oval window generates waves in paralymph, which displace the basilar membrane along a gradient of stiffness. High frequencies peak near the base, low frequencies near the apex. Above the basilar membrane lies the organ of Corti, where inner hair cells transduce mechanical motion into receptor potentials. Stereocilia on these cells bend against the overlying tectorial membrane, opening mechanically gated potassium channels and depolarizing the cell. This triggers neurotransmitter release onto cochlear nerve fibers, initiating auditory signals. Outer hair cells adjust basilar membrane mechanics via electromotility, sharpening frequency tuning. Auditory signals travel via the cochlear nerve to the cochlear nuclei, ascend bilaterally through the superior olivary complex, localizing sound via interaural time and intensity differences, then reach the inferior colliculus and medial geniculate nucleus of the thalamus. From there, fibers project to the primary auditory cortex in the temporal lobe. Tonotopic organization is preserved throughout. Damage along this pathway can cause subtle deficits, but complete hearing loss requires damage before bilateral convergence. Balance or vestibular function begins in the inner ear, where fluid movement deflects hair cells in two types of sensors. The semicircular canals detect angular acceleration. Each canal contains an ampulla with a crista ampullaris, hair cells embedded in a gelatinous cupula. Head rotation displaces endolymph, which lags due to inertia, bending the cupula and stimulating hair cells. The three canals, horizontal, anterior, and posterior, are oriented at right angles, allowing three-dimensional motion detection. The otolith organs, utricle and saccule, detect linear acceleration and head position. Their maculae contain hair cells embedded in a gelatinous layer topped by calcium carbonate crystals, otoconia. Movement or tilt shifts the otoconia, bending the stereocilia. Hair cell output travels via the vestibular nerve to nuclei in the brainstem and cerebellum. Reflexes, such as the vestibular ocular reflex (VOR), stabilize gaze during head movement by driving compensatory eye motion. Integration with visual and proprioceptive input refines orientation. When balance information conflicts, such as on a moving boat, nausea and disorientation can result. This system also interacts with the autonomic nervous system. Sudden shifts can induce sweating, pallor, or changes in blood pressure. Disorders here, like benign paroxysmal positional vertigo, BPPV, vestibular neuritis, or Meniere's disease, disrupt balance with characteristic patterns of nystagmus and unsteadiness. Smell begins in the nasal cavity, where odorant molecules dissolve in mucus and bind to receptors on olfactory sensory neurons. These neurons, located in the olfactory epithelium, each express a single type of odorant receptor from a large gene family. Binding activates a G protein cascade that opens ion channels, depolarizing the neuron. Axons of similar receptors converge in glomeruli within the olfactory bulb, creating a spatial map of odorant types. Second-order neurons, mitral and tufted cells, carry signals along the olfactory tract to the olfactory cortex, amygdala, and entorhinal cortex and other limbic structures. This pathway bypasses the thalamus initially, allowing for fast, emotionally charged perception. Smell plays a subtle but central role in taste, memory, and social interaction. Loss of smell, anosmia, can reflect local inflammation, neurodegeneration, or trauma to the cribriform plate. Because olfactory neurons regenerate, recovery is sometimes possible. Each of these senses translates environmental cues into neural code. They rely on receptor specialization, supporting structures, and precise pathways to preserve fidelity. They're also deeply integrated. Balance links to vision, smell to memory, hearing to orientation. The brain reconstructs a seamless picture from these overlapping streams. At the bedside, a patient with sudden vision loss, vertigo, or hearing change warrants careful mapping. Central lesions cause distinct patterns. Vertical nystagmus or internuclear ophthalmoplegia suggests brainstem pathology. Peripheral vestibular disorders usually produce horizontal nystagmus that suppresses with fixation. Loss of smell, especially when unilateral or persistent, may signal frontal lobe mass or early neurodegenerative disease. Multisensory deficits, especially when acute, require prompt expert evaluation to protect safety and function. A brief reflection, each sense adds a dimension to reality. You feel grounded, oriented, and connected because these systems decode space and substance into certainty. You sense wave and light, vibration and drift, molecule and meaning, each portal tuned, each message delivered without pause. Next, you'll enter the thorax, where a four-chambered pump coordinates pressure, valves, rhythm, and blood supply with precision that sustains every other system. You place your hand on your chest and feel the rhythm beneath, steady, layered, essential. The heart is not just a pump, but a choreographed engine where four chambers, four valves, conduction tissue, and a dedicated blood supply coordinate without rest. These four concepts, chambers, valves, conduction, and coronaries, map the living dynamics that sustain circulation. The heart lies in the mediastinum, angled obliquely behind the sternum. It consists of two upper chambers, atreia, and two lower chambers, ventricles, separated by septa and guarded by valves. The right atrium receives deoxygenated blood from the body via the superior and inferior venae cavae. It passes blood through the tricuspid valve into the right ventricle, which pumps it through the pulmonary valve into the pulmonary trunk and then to the lungs. Oxygenated blood returns to the left atrium via 4 pulmonary veins, enters the left ventricle through the mitral valve, and is ejected through the aortic valve into the systemic circulation. The atrial walls are thin, serving mainly as primers for ventricular filling. The ventricles are thicker and muscular, especially the left, which must generate systemic pressure. The interventricular septum separates the two and contributes significantly to left ventricular output. Internally, the heart is lined by endocardium. Externally, it is surrounded by pericardium, a fibrous sac with a serous double layer that reduces friction. Between these layers lies the pericardial cavity, filled with a small amount of lubricating fluid. Excess fluid accumulation here, pericardial effusion, can impair filling if pressure rises, a condition called cardiac tamponade. Valves ensure one-way flow. The atrioventricular AV valves, tricuspid on the right, mitral on the left, separate atria from ventricles. Each leaflet is anchored by chordae tendineae to papillary muscles in the ventricular walls. These structures do not open the valves but prevent prolapse during systole. The semilunar valves, pulmonary and aortic, guard the outlets of the ventricles. They have 3 cusps each and prevent backflow after ejection. Valve opening and closure are passive, driven by pressure gradients. During ventricular contraction systole, rising pressure closes the AV valves and opens the semilunar valves. During relaxation diastole, pressure drops, closing the semilunar valves and allowing the AV valves to reopen. Valve function creates heart sounds. The first sound S1 marks AV valve closure, the second S2 marks semilunar valve closure. Splitting of these sounds can reflect physiological or pathological timing differences. Murmurs, audible vibrations from turbulent flow, may indicate valve stenosis, narrowing, or regurgitation, incompetent closure. Valve pathology affects preload, afterload, chamber size, and overall cardiac efficiency. For example, mitral regurgitation allows blood to flow backward into the atrium during systole, increasing atrial pressure and volume over time. Conduction tissue coordinates timing. The sinoatrial SA node, located in the right atrium near the superior vena cava, is the heart's natural pacemaker. It initiates impulses that spread through atrial muscle, causing contraction. The signal reaches the atrioventricular AV node near the interatrial septum, where it slows briefly, allowing the ventricles time to fill. From the AV node, impulses descend through the bundle of His, split into right and left bundle branches, and reach the Purkinje fibers that spread through ventricular myocardium. This sequence ensures atrial contraction precedes ventricular contraction, and that ventricular depolarization is rapid and coordinated. On an electrocardiogram ECG, the P wave represents atrial depolarization, the QRS complex reflects ventricular depolarization, and the T wave corresponds to ventricular repolarization. The PR interval reflects AV nodal delay. The QT interval spans depolarization and repolarization. Disturbances in rhythm, arrhythmias, may arise from abnormal automaticity, re-entry circuits, or conduction block. For example, atrial fibrillation produces disorganized atrial impulses, reducing atrial contribution to ventricular filling and increasing stroke risk. Coronary arteries supply oxygenated blood to the myocardium. The left coronary artery LCA arises from the left aortic sinus and quickly branches into the left anterior descending LAD and circumflex arteries. The LAD runs along the anterior interventricular sulcus, supplying the anterior left ventricle and septum. The circumflex follows the atrioventricular groove, serving the lateral and posterior left ventricle. The right coronary artery LCA, from the right aortic sinus, travels in the right AV groove, giving off branches to the right atrium, right ventricle, and often the AV node. It typically gives rise to the posterior descending artery PDA in right dominant circulation, which supplies the inferior wall and posterior septum. Coronary perfusion occurs primarily during diastole, when ventricular pressure falls and vessels are not compressed. Autoregulation matches flow to demand, but atherosclerotic narrowing, vasospasm, or embolism can compromise supply. Ischemia impairs contractility and can lead to infarction, cell death from sustained oxygen deprivation. Infarct location follows arterial distribution. LAD occlusion affects anterior wall and septum. RCA occlusion may impair SA or AV node function. Circumflex blockage threatens the lateral wall. At the bedside, a person with chest pressure radiating to the arm or jaw, especially with shortness of breath or nausea, may be experiencing myocardial ischemia. If symptoms persist or worsen, if hypotension develops, or if consciousness alters, urgent expert evaluation is necessary. Timing is critical for preserving viable myocardium. New murmurs or heart sounds may reflect valve dysfunction or rupture. If the pulse is irregular, if neck veins bulge, or if edema develops, these signs point to dysfunction in the system's pressure management. A brief reflection: the heart's rhythm, valves, timing, and blood supply weave a system that adjusts instantly to need. Its strength lies not in size but in coordination. You feel chambers filling in sequence, valves closing in silence, impulses flowing like clockwork down hidden paths. Next, you'll follow the vessels that carry this effort: arteries, veins, capillaries, and lymphatics, each with tailored walls and roles in pressure, exchange, and cleanup. You press a finger to your wrist and feel a pulse, rhythmic, regular, persistent. That quiet wave is carried through vessels, a branching system that adjusts flow, preserves pressure, permits exchange, and clears debris. 4 vessel types anchor this system: arteries, veins, capillaries, and lymphatics. Arteries carry blood away from the heart under high pressure. Their walls are thick and elastic, built to withstand and buffer pulsatile force. The largest arteries, elastic arteries like the aorta and pulmonary trunk, contain abundant elastin in their tunica media, allowing them to stretch during systole and recoil during diastole. This recoil maintains forward blood flow between heartbeats and smooths the pulse wave, reducing stress on downstream vessels. As arteries branch, they become muscular arteries such as the radial or femoral, where smooth muscle predominates. These arteries control distribution and respond to autonomic signals and local mediators to adjust diameter. Their tunica media is a thick layer of smooth muscle surrounded by internal and external elastic laminae. Further branching produces arterioles, the smallest arteries, which offer the greatest resistance and therefore control systemic blood pressure. Arterioles respond rapidly to sympathetic tone, metabolic needs, and endothelial signals like nitric oxide, which relaxes muscle to increase local perfusion. Veins return blood to the heart at lower pressure. Their walls are thinner and less muscular, but their lumens are larger, allowing for volume accommodation. Veins are more compliant, able to expand with less resistance, making them the primary blood reservoirs of the body. Venous walls include the same 3 layers as arteries: tunica intima, media, and adventitia, but in reduced proportion. Valves formed by enfoldings of endothelium prevent backflow, especially in the limbs. Skeletal muscle contractions and thoraco-abdominal pressure changes during breathing assist venous return, a mechanism called the muscle pump. Large veins like the superior and inferior vena cava drain directly into the right atrium. In contrast to arteries, veins may travel more superficially and form plexuses around joints or viscera. Venous sinuses, such as those in the brain, lack valves and depend on position and pressure gradients to drain. Obstruction or failure of valves can cause pooling and distension, producing varicose veins or contributing to edema. Capillaries are the exchange vessels. They form vast networks at the level of tissues, where they permit gas, nutrient, and waste transfer. Capillary walls are a single layer of endothelial cells resting on a basement membrane thin enough to allow diffusion. There are 3 main types. Continuous capillaries have uninterrupted endothelium and are found in muscle, skin, and the brain. Tight junctions regulate permeability. In the brain, the blood-brain barrier further restricts passage with astrocytic support. Fenestrated capillaries found in kidneys, intestines, and endocrine glands have pores that increase fluid and small solute exchange. Sinusoidal discontinuous capillaries in the liver, spleen, and bone marrow have large gaps and incomplete basement membranes allowing passage of cells and macromolecules. Capillary flow is regulated by precapillary sphincters and meta-arterioles, adjusting perfusion based on tissue demand. Exchange occurs via diffusion, transcytosis, filtration, and bulk flow. Hydrostatic pressure tends to push fluid out of capillaries at the arterial end, while oncotic pressure, mainly due to plasma proteins, draws it back in at the venous end. An imbalance between these forces can cause edema. The surface area and thin walls of capillaries allow for remarkable efficiency. A single cubic millimeter of tissue may contain hundreds of capillaries per square millimeter. Lymphatic vessels recover fluid that escapes the capillary circulation. As blood filters through capillaries, about 10% of plasma volume exits into interstitial spaces and is not reabsorbed. This fluid is picked up by blind-ended lymphatic capillaries, whose overlapping endothelial cells open under interstitial pressure. The lymph, now containing water, proteins, lipids, and sometimes immune cells, travels through progressively larger lymphatic vessels that pass through lymph nodes. Lymph nodes filter the fluid, exposing it to resident immune cells that monitor for pathogens or debris. Valves in lymphatic vessels ensure one-way flow, and skeletal muscle and respiratory motion assist propulsion. Eventually, lymph drains into the venous system at the junction of the internal jugular and subclavian veins, on the right via the right lymphatic duct and on the left via the thoracic duct. If lymph drainage fails, protein-rich fluid accumulates, causing non-pitting lymphedema, often seen after lymph node dissection or radiation. These four systems, arterial delivery, venous return, capillary exchange, and lymphatic recovery, cooperate to maintain homeostasis. Arteries provide pressure, arterioles direct flow, capillaries allow transfer, veins return volume, lymphatics clear the excess. The endothelium lining all vessels serves as more than a barrier. It senses shear stress, releases vasoactive substances, regulates coagulation, and interacts with immune cells. Injury to this layer initiates a cascade: platelet adhesion, clot formation, and inflammation, all central to disease processes like atherosclerosis and thrombosis. At the bedside, swollen, tender legs with asymmetry may suggest deep vein thrombosis. If chest pain and shortness of breath follow, a pulmonary embolism must be considered. Red, inflamed streaks tracking proximally suggest lymphangitis. Swelling that persists without redness or pain may indicate lymphatic compromise. In another patient, cold, pale, pulseless extremities with pain suggest acute arterial occlusion, an emergency requiring immediate intervention to restore flow. Bruits, asymmetric pulses, or blood pressure differences between limbs may point to arterial stenosis or dissection. A brief reflection: vessels shape pressure into function. Their architecture echoes their purpose. Some resisting, some pooling, some exchanging, all balancing fluid and motion. You trace branching paths from the chest into limbs, organs, and skin, each lumen quiet, each wall purposeful. Next, you'll examine what flows within these vessels: blood's cellular components, how they patrol, carry, patch, and remember, and what happens when those functions falter. You see blood as a red stream, but inside that river, each drop contains thousands of purposeful agents, cells that transport, defend, patch, and remember. Blood is not a fluid alone, it's a living tissue in motion. Its four essential components, cells, hemostasis, blood groups, and immunity, coordinate to sustain life silently, adjusting minute by minute to internal demands. Start with its composition. Blood consists of plasma and formed elements. Plasma, the straw-colored liquid, makes up about 55% of total volume and carries water, proteins, albumin, globulins, fibrinogen, electrolytes, nutrients, hormones, and waste products. The remaining 45% comprises red blood cells, erythrocytes, white blood cells, leukocytes, and platelets, thrombocytes. Each category serves a different mission, but all arise from hematopoietic stem cells in the bone marrow. Erythrocytes transport oxygen. They are biconcave, enucleate cells rich in hemoglobin, a tetrameric protein with iron-containing heme groups that bind oxygen reversibly. Their shape maximizes surface area for gas exchange and flexibility for capillary passage. Lacking mitochondria, they rely on anaerobic glycolysis. Lifespan averages 120 days. Aged cells are removed by macrophages in the spleen, liver, and bone marrow. Iron is recycled, globin chains broken down, and heme converted to bilirubin. Disruption of erythrocyte production or survival leads to anemia, fatigue, pallor, and reduced oxygen delivery. Leukocytes defend the body. Divided into granulocytes and agranulocytes, each subtype plays a distinct immune role. Neutrophils are the most abundant and the first responders in bacterial infection. They phagocytose pathogens and release enzymes and reactive oxygen species. Eosinophils combat parasites and modulate allergic responses. Basophils release histamine and mediate hypersensitivity. Lymphocytes, B cells, T cells, and natural killer NK cells handle specific immune recognition and memory. Monocytes circulate briefly, then enter tissues as macrophages or dendritic cells, clearing debris and presenting antigens. Leukocyte counts vary with infection, inflammation, or malignancy. Patterns of increase or decrease help guide clinical insight. Platelets are cell fragments derived from megakaryocytes. They contain granules rich in clotting factors, signaling molecules and enzymes. On vascular injury, platelets adhere to exposed collagen via von Willebrand factor, become activated, change shape, and release contents that recruit and activate more platelets. This forms a temporary plug and initiates the coagulation cascade. Fibrin, produced through a series of enzymatic steps involving clotting factors, stabilizes the plug into a durable clot. Once healing proceeds, fibrinolysis breaks down the clot to restore normal flow. This sequence, vascular constriction, platelet plug, fibrin mesh, is known as primary and secondary hemostasis. Hemostasis must balance two dangers: uncontrolled bleeding and unwanted clotting. Inherited or acquired disorders of platelets or clotting factors tilt this balance. Hemophilia A factor VIII deficiency and von Willebrand disease impair clot formation. Conversely, excessive activation of coagulation, such as in deep vein thrombosis or pulmonary embolism, can obstruct vital vessels. Clinical evaluation involves platelet count, coagulation studies, prothrombin time, activated partial thromboplastin time, and sometimes specific factor assays. Blood groups reflect antigens on the erythrocyte surface. The ABO system includes A, B, AB, and O types, based on the presence or absence of A and B antigens. The Rh system, especially the D antigen, adds another layer. Type O negative is considered a universal donor for red cells. AB positive is a universal recipient. Transfusion safety depends on matching not just ABO and Rh, but also minor antigens to reduce alloimmunization. Mismatched transfusions trigger hemolysis, destruction of donor erythrocytes, and can cause fever, hypotension, renal failure, or shock. Pre-transfusion testing includes blood typing, antibody screening, and cross-matching. Beyond red cells, plasma and platelets carry antigens and must also be matched carefully. The Rh factor is especially significant in pregnancy. An Rh-negative mother carrying an Rh-positive fetus may develop antibodies that affect future pregnancies, a process called hemolytic disease of the newborn, preventable by Rh immunoglobulin. Immunity extends beyond white cells to memory and tolerance. The innate immune system provides rapid, nonspecific defense: skin, mucosa, phagocytes, and complement. The adaptive system offers specificity and memory. B lymphocytes produce antibodies, tagging pathogens for destruction or neutralization. Taggy lymphocytes come in subtypes: helper T cells, CD4 POS, coordinate immune responses; cytotoxic T cells, CD8 POS, kill infected cells; regulatory T cells modulate tolerance, preventing autoimmunity. Memory cells persist after infection or vaccination, allowing rapid reactivation on re-exposure. The immune system's intelligence is trained in primary lymphoid organs, the bone marrow for B cells and thymus for T cells. It is deployed through secondary organs, lymph nodes, spleen, tonsils, and gut-associated lymphoid tissue where surveillance continues. When functioning well, the system defends with precision. When dysregulated, it causes allergy, autoimmunity, or immunodeficiency. In infection, inflammatory markers like C-reactive protein rise. Leukocyte counts shift, antibodies appear. In autoimmunity, the body mistakes self for threat. In malignancy, immune cells may be co-opted or silenced. At the bedside, a person with unexplained bruising, nosebleeds, or prolonged bleeding from minor cuts may have a hemostatic disorder. Petechiae suggest platelet dysfunction. Deep muscle bleeds point toward clotting factor deficiency. Fever with high neutrophil counts may signal bacterial infection. High lymphocytes suggest viral causes. Severe anemia causes fatigue, shortness of breath, and pallor. Rapid onset raises concern for blood loss or hemolysis. If multiple cell lines are low, marrow dysfunction must be considered. New fever in an immunocompromised host requires urgent evaluation. Without defense, even mild infections become threats. A brief reflection: blood is not merely a transport, it's a circulating population of sensors, defenders, and repair crews. Each element contributes its strength and restraint and balance. You picture a moving city, red couriers, white sentinels, platelets, patching roads, plasma ferrying resources across the map. Next, you'll explore how oxygen enters this bloodstream. Airways, alveoli, pressure gradients, and the coordination between air and blood that lets each breath nourish the body. You inhale gently, and without thought, oxygen enters, carbon dioxide leaves, and a silent exchange sustains life. The respiratory system manages this balance through 4 functional elements: airways, alveoli, ventilation, and perfusion. Each part is engineered for precision, adjusting to need while preserving delicate tissue exposed to the environment. Air enters through the nasal cavity or mouth, passing into the pharynx and larynx before reaching the trachea. The trachea, a rigid tube supported by C-shaped cartilaginous rings, splits into 2 main bronchi, right and left, each entering a lung at the hilum. The right bronchus is wider, shorter, and more vertical, making it the more common site for aspirated objects. Bronchi branch into secondary lobar and tertiary segmental bronchi, each supplying defined lung segments. These further divide into bronchioles, airways less than 1 mm in diameter, lacking cartilage but rich in smooth muscle. Terminal bronchioles mark the end of purely conducting airways. Beyond this, respiratory bronchioles give rise to alveolar ducts and sacs, where gas exchange begins. This transition from conducting to respiratory zone is gradual, increasing surface area and decreasing resistance. The airway walls change along the path. Larger bronchi are lined with pseudostratified ciliated columnar epithelium, with goblet cells producing mucus. Smaller bronchioles shift to simple cuboidal cells with fewer goblet cells and more Clara cells, which secrete surfactant components and detoxifying enzymes. Alveoli are thin-walled sacs where gas exchange occurs. Each lung contains hundreds of millions, totaling roughly 70 square meters of surface area, comparable to a tennis court. Their walls are composed of type I pneumocytes, flat, thin cells covering most of the surface, and type II pneumocytes, cuboidal cells that secrete surfactant and regenerate the epithelium. Surfactant reduces surface tension, preventing alveolar collapse during exhalation. It becomes critical in premature infants, where deficiency causes respiratory distress syndrome. The alveolar capillary barrier is optimized for diffusion. Oxygen and carbon dioxide pass across the thin alveolar epithelium, shared basement membrane, and capillary endothelium. The driving force is the partial pressure gradient. Inspired air has a high oxygen partial pressure. Mixed venous blood entering pulmonary capillaries has lower oxygen and higher carbon dioxide. This gradient ensures net oxygen entry and carbon dioxide removal. The system adjusts rapidly. Exercise increases cardiac output and opens previously underused capillaries, matching ventilation with demand. Ventilation moves air in and out of the lungs. It begins with inspiration, an active process where the diaphragm contracts, flattening downward, and external intercostal muscles lift the rib cage. This expands the thoracic cavity, lowering intrapleural pressure and drawing air in. Expiration is typically passive. Elastic recoil of lungs and chest wall returns air to the atmosphere. In forced expiration, abdominal and internal intercostal muscles engage. The mechanics depend on compliance and resistance. Compliance measures how easily the lungs expand. Decreased compliance, as in fibrosis, requires greater effort. Resistance reflects airway diameter. Narrower airways increase resistance, as seen in asthma or bronchitis. Lung volumes reflect function. Tidal volume is the normal breath. Vital capacity is the maximum, exhaled after full inspiration. Residual volume is the air remaining after full exhalation. These volumes and flows are measured in spirometry, revealing obstructive reduced flow or restrictive reduced volume patterns. Perfusion delivers blood to the alveoli. The pulmonary arteries carry deoxygenated blood from the right ventricle to the lungs, branching alongside the airways. Pulmonary capillaries surround alveoli closely, forming an efficient interface. After gas exchange, oxygenated blood returns to the left atrium via pulmonary veins. The pulmonary circulation is low pressure and low resistance, accommodating increased flow with little rise in pressure. Hypoxic vasoconstriction, a unique response, diverts blood away from poorly ventilated regions, improving matching between air and blood. This matching ventilation-perfusion VQ coupling is vital. Ideally, each alveolus receives air and blood in proportion. When mismatched, gas exchange suffers. A region with ventilation but no perfusion, dead space, contributes no oxygen. A region with perfusion but no ventilation adds deoxygenated blood to the output. Conditions like pulmonary embolism, chronic obstructive pulmonary disease, COPD, or pneumonia create VQ mismatch, reducing efficiency and causing hypoxemia. At rest, the base of the lung receives more perfusion and ventilation than the apex due to gravity, but perfusion differences are greater, creating a mild mismatch. This gradient becomes clinically significant in disease states or when patients are positioned differently. The body compensates through local mechanisms, bronchoconstriction in underperfused areas, vasoconstriction in underventilated ones, and through systemic responses like increased respiratory rate. At the bedside, a person with shortness of breath, cyanosis, or chest pain may be experiencing impaired gas exchange, rapid breathing with low oxygen saturation, especially if new or worsening warrants immediate attention. A sudden drop in oxygen with clear lung sounds suggests a pulmonary embolism. Diffuse crackles and effortful breathing point to alveolar filling processes like pneumonia or pulmonary edema. In chronic conditions like COPD, prolonged expiration and barrel chest suggest airflow limitation. When hypoxia is accompanied by confusion, fatigue, or altered consciousness, urgent intervention is required to restore oxygen delivery. A brief reflection. Each breath is more than air. It's a calibrated exchange, shaped by architecture and mechanics, sustained without command. You feel pressure drop and ribs lift, alveoli stretch open, and capillaries quietly trade gases with the precision of trust. Next, you'll follow this air deeper into digestion, where food becomes fuel, enzymes and organs coordinate, and absorption unfolds from mouth to colon. You swallow a bite of food, and without your direction, a wave begins, chewing, mixing, propelling, digesting, absorbing, and reclaiming water. The digestive system manages these tasks through a long muscular tube and its accessory organs. 4 key domains, mouth to colon transit, liver, pancreas, and absorption, shape how the body extracts energy and builds itself anew. The gastrointestinal GI tract begins at the mouth. Mechanical digestion starts with mastication, chewing, breaking food into smaller pieces. Salivary glands, parotid, submandibular, sublingual, secrete saliva containing amylase, which starts carbohydrate breakdown, lipase, mucus, and antimicrobial agents. The tongue shapes food into a bolus and pushes it to the oropharynx, triggering a coordinated swallowing reflex. This reflex temporarily closes the nasopharynx and larynx while the bolus enters the esophagus. The esophagus is a muscular tube connecting pharynx to stomach. It propels food via peristalsis, sequential, coordinated contractions of smooth muscle. At its distal end, the lower esophageal sphincter, LES, relaxes to allow entry into the stomach, then contracts to prevent reflux. Dysfunction here leads to gastroesophageal reflux disease, GERD, where acid escapes the stomach and irritates the esophagus. The stomach stores and processes food. Its muscular wall churns contents with gastric secretions. Parietal cells secrete hydrochloric acid, an intrinsic factor essential for vitamin B12 absorption. Chief cells release pepsinogen, which acid activates into pepsin to digest proteins. Mucus cells protect the lining with bicarbonate-rich mucus. The stomach's low pH denatures proteins and kills pathogens. The pyloric sphincter controls gastric emptying into the duodenum, regulating the entry of chyme, a semi-liquid food mixture. The small intestine, duodenum, jejunum, ileum, is the primary site for digestion and absorption. In the duodenum, chyme mixes with bile from the liver and digestive enzymes from the pancreas. The jejunum is rich in absorptive villi and microvilli, increasing surface area for nutrient uptake. The ileum continues absorption, particularly of bile salts and vitamin B12. Coordinated peristalsis and segmentation, mixing contractions ensure thorough exposure to the mucosa. The large intestine, cecum, colon, rectum, absorbs water and electrolytes, compacts waste, and stores feces. Its slower motility allows maximal fluid recovery. Resident microbiota ferment undigested carbohydrates, synthesize certain vitamins, e.g., vitamin K, and influence immune function. The rectum senses distension, initiating the defecation reflex via the internal and external anal sphincters. The liver plays multiple roles. It produces bile, a detergent-like fluid containing bile acids, bilirubin, cholesterol, and electrolytes. Bile emulsifies fats, increasing surface area for pancreatic lipases to act. Bile is stored and concentrated in the gallbladder, then released into the duodenum in response to cholecystokinin (CCK) during meals. The liver receives dual blood supply, oxygenated blood from the hepatic artery and nutrient-rich deoxygenated blood from the portal vein. This arrangement allows hepatocytes to process nutrients absorbed from the gut. The liver synthesizes plasma proteins, albumin, clotting factors, converts excess glucose to glycogen, glycogenesis, produces ketones, detoxifies substances via cytochrome P450 enzymes, and excretes waste and bile. It also stores vitamins and iron. Bilirubin, derived from hemoglobin breakdown, is conjugated in the liver and excreted in bile. Impaired conjugation or excretion leads to jaundice. The pancreas has exocrine and endocrine functions. Its exocrine portion, acinar cells, secretes digestive enzymes, amylase for carbohydrates, lipase for fats, and proteases, trypsin, chymotrypsin for proteins. These enzymes are secreted as zymogens, inactive forms, to prevent autodigestion, then activated in the duodenum. The ductal cells also secrete bicarbonate to neutralize gastric acid, creating an optimal pH for enzymes. Endocrine function arises from the islets of Langerhans. Alpha cells secrete glucagon, which raises blood glucose. Beta cells release insulin, which lowers glucose by promoting uptake and storage. Delta cells release somatostatin, which inhibits both. The balance of insulin and glucagon maintains glucose homeostasis, adjusting between feeding and fasting states. Absorption occurs through the small intestinal epithelium. Carbohydrates are broken into monosaccharides, glucose, galactose, fructose, and absorbed via sodium-linked transporters. Proteins become amino acids and small peptides, absorbed by active transport. Fats are emulsified by bile, digested into free fatty acids and monoglycerides, and absorbed into enterocytes. There they are reassembled into triglycerides, packaged into chylomicrons, and enter lymphatic vessels, lacteals, before reaching circulation. Vitamins and minerals follow varied paths. Water-soluble vitamins B, C absorb via passive or active transport. Fat-soluble vitamins A, D, E, K require micelle formation. Calcium and iron are absorbed in the duodenum under regulation. Vitamin D increases calcium absorption. Iron absorption is modulated by body stores and hepcidin levels. Electrolytes like sodium and potassium follow osmotic gradients. Water follows solutes by osmosis. The gut barrier protects against pathogens while allowing nutrient entry. Tight junctions between epithelial cells regulate percellular flow. Secretory IgA and mucus provide immune defense. Disruption by inflammation, infection, or ischemia compromises this barrier and can lead to systemic effects. At the bedside, a person with weight loss, diarrhea, and nutrient deficiencies may have malabsorption. If symptoms include steatorrhea, fatty stools, bloating, or fatigue, causes may include pancreatic insufficiency, celiac disease, or small intestinal bacterial overgrowth. Jaundice, dark urine, and pale stools suggest biliary obstruction or hepatocellular dysfunction. If upper abdominal pain radiates to the back, especially after meals, pancreatitis must be considered. Bloody diarrhea with fever may signal colitis. Any combination of abdominal pain, altered bowel habits, or bleeding warrants careful evaluation. A brief reflection. Digestion is a silent assembly line. Each segment times its release, shapes its surface, and coordinates with others to turn meals into molecules of life. You trace enzymes from glands to gut, emulsions forming, villi absorbing, nutrients entering with careful permission. Next, you'll follow waste as it is filtered and refined into the kidneys, where nephrons edit blood, manage electrolytes, and sustain chemical balance drop by drop. You sip water, and within hours it moves through your bloodstream, filtered, adjusted, and, if in excess, quietly excreted. The kidneys manage this transformation drop by drop. Their mechanisms are layered but deliberate. guided by 4 structural and functional units: nephrons, filtration, reabsorption/secretion, and regulation. Each kidney contains roughly 1 million nephrons, the functional units that filter blood and create urine. A nephron begins with a glomerulus, a tuft of capillaries encased in Bowman's capsule, forming the renal corpuscle. Blood enters the glomerulus via an afferent arteriole and exits via an efferent arteriole. The difference in arteriolar diameter generates pressure that drives plasma filtration. From the capsule, the filtrate flows into the proximal convoluted tubule (PCT), then the loop of Henle distal convoluted tubule (DCT), and finally the collecting duct. Cortical nephrons, located near the kidney surface, have short loops and handle most solute reabsorption. Juxtamedullary nephrons extend deeper into the medulla and specialize in concentrating urine, aided by their long loops and associated vasa recta capillaries. The nephron segments have distinct epithelial linings and transporter profiles, tailored for reabsorbing or secreting specific substances. Filtration at the glomerulus is a selective process. The filtration membrane consists of 3 layers: fenestrated capillary endothelium, a shared basement membrane, and podocytes, specialized epithelial cells with interdigitating foot processes. This structure blocks large proteins and cells while allowing water, electrolytes, glucose, and small solutes to pass. The resulting filtrate is protein-free and isotonic with plasma. The glomerular filtration rate (GFR) reflects kidney function and is tightly regulated. Normal adult GFR averages about 120 ml/min. It depends on capillary hydrostatic pressure, plasma oncotic pressure, and Bowman's capsule pressure. Autoregulation stabilizes GFR over a range of blood pressures using 2 main mechanisms: the myogenic response, afferent arteriole constricts when stretched, and tubule-glomerular feedback, macula densa cells detect sodium levels and signal arteriolar adjustment. Disruption by low blood pressure, nephron injury, or vasoconstrictors can reduce filtration and compromise clearance. Reabsorption and secretion occur along the nephron's tubules. In the PCT, about 65% of filtered sodium, water, and other solutes are reabsorbed. Sodium is reabsorbed actively via Na plus K plus ATPase pumps, creating gradients that drive passive water movement. Glucose, amino acids, bicarbonate, phosphate, and other substances follow via cotransporters or facilitated diffusion. The PCT also secretes organic acids and bases, metabolites, drugs, toxins into the filtrate. The loop of Henle establishes a countercurrent multiplier system. The descending limb is permeable to water but not solutes. Water exits into the hyperosmotic medullary interstium. The ascending limb, impermeable to water, actively transports sodium, potassium, and chloride out of the tubule. This separation of water and solute reabsorption builds an osmotic gradient that allows for urine concentration in the collecting duct. In the DCT and collecting duct, hormone-sensitive transport fine-tunes reabsorption. Aldosterone, released from the adrenal cortex in response to angiotensin II or hyperkalemia, increases sodium reabsorption and potassium secretion in the late DCT and cortical collecting duct. Antidiuretic hormone, ADH, secreted by the posterior pituitary, inserts aquaporin II channels into the collecting duct membrane, enhancing water reabsorption and concentrating urine. Regulation of acid-base balance also occurs here. Hydrogen ions are secreted. Bicarbonate is reabsorbed or regenerated depending on pH. Intercalated cells in the collecting duct modulate this exchange, maintaining systemic pH within narrow limits. Chronic imbalances, acidosis or alkalosis, reflect disturbances in this buffering system or in respiratory compensation. The kidneys integrate with multiple systems to regulate volume, pressure, and osmolarity. The renin-angiotensin-aldosterone system, RAS, begins when juxtaglomerular cells sense decreased perfusion and secrete renin. Renin converts angiotensinogen to angiotensin I, which is converted to angiotensin II by angiotensin-converting enzyme AC in the lungs. Angiotensin II constricts vessels, stimulates thirst, and promotes aldosterone release, all restoring volume and pressure. Erythropoietin, produced by interstitial fibroblasts in response to hypoxia, stimulates red blood cell production in the bone marrow. Vitamin D is activated in the kidney via 1-alpha hydroxylase, enabling calcium absorption in the gut. Thus, the kidney intersects with hematologic, skeletal, and endocrine systems. At the bedside, a person with swelling, high blood pressure, or changes in urination may signal renal dysfunction. Foamy urine may suggest protein loss. Bloody urine may indicate glomerular injury. If potassium rises unexpectedly, if acid-base status worsens, or if fluid accumulates in the lungs, urgent evaluation is needed. In acute kidney injury, rising creatinine and declining urine output demand immediate attention. In chronic disease, subtle symptoms, fatigue, pruritus, anemia, may precede more obvious signs. When GFR falls persistently below thresholds, replacement therapy, dialysis, or transplantation may be necessary. Brief reflection: the kidneys do not just filter, they calculate volume, pressure, osmolarity, and acid-base status, all continuously and quietly. You visualize millions of nephrons sifting, reclaiming, and deciding, with each tubule acting like a tiny refinery of balance. Next, you'll enter the endocrine system, where distant signals, hormones, coordinate metabolism, growth, stress, and reproduction through chemical messengers moving silently through blood. You feel hunger rise, temperature shift, heart race, none from conscious command. These changes reflect hormones, distant messengers released into blood, acting on targets across the body. The endocrine system orchestrates these responses through 4 domains: glands, hormone types, feedback loops, and integration. Endocrine glands release hormones directly into the bloodstream, without ducts. The major glands include the hypothalamus, pituitary, thyroid, parathyroids, adrenal glands, pancreas, and gonads. Each gland has a distinct role but communicates across shared axes. The hypothalamus links the nervous and endocrine systems. It detects internal states, temperature, osmolarity, stress, and produces releasing or inhibiting hormones. These travel via the hypophyseal portal system to the anterior pituitary, which releases trophic hormones that act on peripheral glands. The anterior pituitary secretes 6 key hormones: thyroid-stimulating hormone, TSH, adrenocorticotropic hormone, ACTH, luteinizing hormone, LH, follicle-stimulating hormone, FSH, growth hormone, GH, and prolactin. Each follows a regulated axis. TSH stimulates the thyroid, ACTH stimulates the adrenal cortex, LH and FSH target the gonads, GH promotes growth and metabolism, while prolactin supports lactation. The posterior pituitary stores and releases oxytocin and antidiuretic hormone, ADH, synthesized in the hypothalamus. The thyroid gland produces thyroxine T4 and triiodothyronine T3, which regulate metabolic rate, heat production, and development. Iodine is essential for synthesis. T3 is more active than T4. Most T4 is converted peripherally. The thyroid also secretes calcitonin, which lowers blood calcium by inhibiting osteoclast activity. Parathyroid glands, small nodules on the thyroid's posterior surface, produce parathyroid hormone, PTH, which raises blood calcium. PTH stimulates bone resorption, increases renal calcium reabsorption, and activates vitamin D, enhancing intestinal calcium absorption. It lowers phosphate by increasing excretion. The adrenal glands sit atop the kidneys. The cortex has 3 zones. The outer zona glomerulosa makes aldosterone, salt balance. The zona fasciculata produces cortisol, stress and metabolism, and the zona reticularis makes androgens, sex precursors. The medulla, under sympathetic control, secretes catecholamines, epinephrine and norepinephrine in response to stress, increasing heart rate, blood glucose, and vascular tone. The pancreas functions as both endocrine and exocrine organ. In the islets of Langerhans, beta cells secrete insulin in response to elevated blood glucose. Alpha cells release glucagon when glucose is low. Insulin promotes glucose uptake and storage as glycogen, fat, and protein. Glucagon mobilizes glucose through glycogenolysis and gluconeogenesis. Together, they maintain euglycemia. Hormones fall into 3 broad types. Peptide hormones like insulin or TSH are made from amino acids and act via membrane receptors, often triggering second messenger cascades. Steroid hormones like cortisol or estrogen derive from cholesterol, cross cell membranes, and bind nuclear receptors to influence gene transcription. Amine hormones, like thyroid hormones and catecholamines, are synthesized from tyrosine and may act like either peptides or steroids depending on structure. Hormones circulate in free or bound forms. Many have carrier proteins that stabilize their half-life and regulate activity. The action depends on receptor presence. Cells without the matching receptor are unaffected. Receptors may be upregulated or downregulated based on chronic hormone levels, altering sensitivity. Most endocrine axes are governed by negative feedback loops. For example, rising cortisol levels suppress ACTH and CRH release. High thyroid hormone levels suppress TSH. This feedback ensures stability. Disruption leads to overproduction, as in autonomous adenomas, or deficiency, as in gland destruction. In contrast, some hormones follow positive feedback. Oxytocin in labor intensifies contractions until delivery. Integration allows hormones to coordinate across systems. During stress, cortisol mobilizes energy stores, dampens immunity, and enhances vascular tone. Growth hormone promotes linear growth, protein synthesis, and lipolysis. Insulin and glucagon manage fuel transitions between fed and fasting states. Reproductive hormones, estrogens, progesterone, testosterone, regulate sexual development, cycles, and fertility. The pineal gland secretes melatonin in response to darkness, helping regulate circadian rhythms. Hormonal rhythms can be pulsatile, diurnal, or cyclical. Cortisol peaks in early morning. Melatonin rises at night. LH and FSH follow monthly cycles in females. These rhythms matter. Testing at the wrong time may miss dysfunction. At the bedside, symptoms like fatigue, weight change, temperature intolerance, or mood swings may reflect endocrine imbalance. A slow pulse, dry skin, and constipation suggest hypothyroidism. Palpitations, tremor, and weight loss suggest hyperthyroidism. Unexpected weight gain with stretch marks and hypertension may indicate Cushing's syndrome. Polyuria and thirst may stem from diabetes mellitus or insipidus. Visual changes, headache, or hormonal loss suggest pituitary mass. Signs of calcium imbalance, cramps, bone pain, or confusion warrant attention to parathyroid and vitamin D status. A brief reflection: hormones whisper across the bloodstream, directing distant organs with brevity and precision. You imagine small glands pulsing signals into blood, organs adjusting silently, their chemistry tuned moment by moment. Next, you'll turn to reproduction, how anatomy and hormones collaborate in cycles, conception and development. From gametes to gestation, you sense rhythms, cycles of growth, preparation, creation that sustain life across generations. Reproduction is both structural and hormonal, sculpted for continuity yet individualized in pattern. 4 ideas help you see this system clearly: gametogenesis, cycles, pregnancy, and pelvic anatomy. Gametogenesis produces sex cells. In males, spermatogenesis occurs in seminiferous tubules of testes. Spermatogenesis divide mitotically, then differentiate into primary spermatocytes that undergo meiosis I to produce secondary spermatocytes, which in turn undergo meiosis II to yield spermatids. These mature into spermatozoa with heads containing DNA, midpieces loaded with mitochondria, and tails, flagella for motility. Sertoli cells support and nourish developing cells. Leydig cells between tubules produce testosterone. In females, oogenesis begins before birth. Oogenesis undergo mitosis and enter meiosis I but arrest at prophase until puberty. Each month, one primary oocyte completes meiosis I to form a secondary oocyte and polar body. Ovulation releases the secondary oocyte, arrested in metaphase II to await fertilization, which, if it occurs, completes meiosis II. Reproductive cycles regulate fertility. In females, the menstrual cycle includes follicular, ovulatory, luteal, and menstrual phases. Follicle-stimulating hormone, FSH, stimulates follicular growth in ovaries. Rising estrogen prepares the endometrium. A surge of luteinizing hormone, LH, triggers ovulation. After release, the corpus luteum forms, secreting progesterone and estrogen to maintain endometrium. If fertilization fails, the corpus luteum regresses, hormone levels drop, and the endometrial lining sheds. In males, spermatogenesis is ongoing, regulated by gonatropic hormones and testosterone, with daily rhythmicity though not with a strict monthly pattern. Pregnancy transforms systems. After fertilization, the zygote divides to form a blastocyst which implants into the uterine wall. The placenta develops, serving both as organ of exchange and endocrine center, producing human chorionic gonadotropin, HCG, progesterone, estrogens, and human placental lactogen. Maternal blood volume increases, cardiac output rises, respiratory capacity grows, renal filtration increases, metabolism shifts to support fetal growth and maintain nutrient supply. The uterus expands, breasts prepare for lactation under hormonal influence. Pelvic anatomy supports reproduction and influences childbirth and gait. The bony pelvis consists of the ilium, ischium, and pubis, fused in adulthood, forming acetabulum and pelvic inlet and outlet. Sexual dimorphism is prominent. Female pelvis tends to be broader, more oval inlet, wider subpubic angle, and a wider pelvic outlet to facilitate delivery. Muscles of the pelvic floor, levator ani, coccygeus, support pelvic organs and resist descent under intra-abdominal pressure. In pregnancy, ligaments relax, mobility increases to permit passage of fetus. The birth canal includes maternal soft tissue and maternal pelvis. Fetal position and orientation presentation influence delivery mechanics. Together, gametogenesis, cycles, pregnancy, and pelvic structure coordinate to permit reproduction that is energy efficient and structurally adapted. Hormones alone do not suffice. Anatomy shapes pathways, allows space, supports load, and ensures safe transport during labor. Abnormalities of cycle, e.g., anovulation, impair fertility. Structural issues, uterine shape, tubal patency, pelvic obstruction matter in conception and delivery. At the bedside, a patient with irregular cycles, abnormal uterine bleeding, or painful periods may have endocrine imbalance, structural lesions, fibroids, endometriosis, or ovulatory dysfunction. Failure to conceive after repeated cycles raises evaluation for male and female factors. Pregnancy with rising hypertension, proteinuria, or bleeding calls for close monitoring. Pelvic pain, mass, or asymmetry may reflect anatomic variation needing imaging. When presentation deviates from expected norm, early evaluation protects both maternal and fetal health. A brief reflection: reproduction balances monthly rhythms with structure and growth, a dance of organs and hormones tuned for continuity. You picture tiny gametes forming, follicles rising, a uterus expanding, bones braced, all preparing life's next breath. Next, you will unite the parts: how homeostasis, aging, anatomic variance, imaging techniques, and emergencies integrate all prior systems into lived experience. You step back and see the body as a whole, its systems interconnected, its balance preserved through silent adjustment. The final layers of anatomical understanding reveal how these parts unite in practice through 5 integrative lenses: homeostasis, aging, variation, imaging, and emergencies. Homeostasis is the body's ability to maintain internal stability despite external change. Every organ system contributes. The nervous system detects and directs. The endocrine system fine-tunes through hormones. The renal and respiratory systems adjust pH and fluid balance. The integument regulates temperature and barrier function. Feedback loops dominate this control, primarily negative feedback where deviation from a set point triggers a correction. For instance, if blood pressure falls, baroreceptors signal the brainstem to increase sympathetic tone, raise heart rate, and restore perfusion. If glucose rises, insulin lowers it by promoting cellular uptake. Stability is not inertia, it is active, dynamic recalibration. With aging, structure and function shift. Bones become thinner and more porous, joint cartilage wears down, muscle mass declines, sarcopenia, neurons slow conduction, vessels stiffen, raising blood pressure, renal filtration rate falls, and hormonal rhythms flatten. The skin loses elasticity and moisture. Some changes are adaptive, others reduce reserve and increase vulnerability. Importantly, anatomical structures do not disappear, they change in density, hydration, or elasticity. The brain may shrink slightly, but key functional pathways often persist into old age unless overt pathology intervenes. Anatomic variation is normal. No two bodies are identical. Variations exist in vessel branching, nerve courses, muscle size, and organ position. Most are benign, but some affect function or surgical planning. For example, a retroesophageal right subclavian artery may compress the esophagus, dysphagia lusoria. A duplicated ureter may drain a kidney into an abnormal position, affecting flow or risking reflux. A left-dominant coronary circulation alters myocardial perfusion territories. Recognition of these variants is vital in imaging, surgery, and emergency care. What seems abnormal may be a personal blueprint. Imaging opens internal anatomy to view without incision. X-rays reveal bone density, joint spacing, and some soft tissue outlines. CT scans offer cross-sectional detail, ideal for trauma, vascular mapping, and lung assessment. MRI uses magnetic fields and radiofrequency to show high-contrast images of soft tissues, brain, joints, spine. Ultrasound visualizes real-time movement and fluid interfaces, ideal for cardiac function, fetal growth, or guided procedures. Each modality relies on anatomical knowledge, planes, densities, relationships. Interpreting a liver mass, spinal lesion, or vessel blockage depends on knowing what should be there and what shouldn't. Emergencies test the integration of systems. In trauma, airway, breathing, and circulation, the ABCs are assessed in sequence. A fractured rib may compromise ventilation. A pelvic fracture may cause hidden hemorrhage. In myocardial infarction, occluded coronaries threaten myocardium, pain, conduction block, or sudden collapse. In stroke, a blocked artery to the brain disrupts speech, movement, or consciousness. In sepsis, systemic inflammation deranges perfusion and organ function. The response must be anatomical, securing airways, relieving pressure, restoring flow, guided by physiology and pathophysiology. These integrative lenses, homeostasis, aging, variation, imaging, and emergencies, remind us that anatomy is not frozen in time or structure. It flexes with need, degrades with age, varies across individuals, becomes visible with tools, and determines outcomes in crisis. A deep anatomical foundation allows clinicians to detect subtle signs, plan safe interventions, and restore disrupted systems with precision. At the bedside, a person presenting with sudden weakness, high fever, unexplained weight loss, or trauma requires rapid assessment grounded in structure. Is the airway patent? Is perfusion adequate? Is this vessel blocked? This organ swollen? This joint misaligned? Anatomy becomes life-saving knowledge when time is short. But even in routine care, palpating an enlarged thyroid, locating a mass in the abdomen, evaluating breath sounds, it is anatomy that guides the hands and decisions. A brief reflection: anatomy is not a list, it is a map in motion, shaped by time, tuned by signals, and vital in every setting from exam room to ICU. You picture systems co-regulating, lungs with heart, glands with kidneys, nerves with vessels, all in dialogue, all in balance. Next, you will complete your journey with 5 final concepts, rounding to 100 and close the arc of the body's anatomy, logic, and quiet power. You arrive at the final chamber, 5 final concepts that complete the journey to 100: fascia, lymph nodes, anatomical spaces, referred pain, and surface anatomy. These are not isolated facts, but cross-cutting ideas that help you navigate the body in real time, palpating, diagnosing, and acting with precision. Fascia is connective tissue that wraps, separates, and connects muscles, organs, and neurovascular bundles. Superficial fascia lies just beneath the skin, containing fat, vessels, and nerves. Deep fascia forms strong, fibrous layers that compartmentalize muscle groups, provide pathways for vessels, and help transmit force. For example, the thoracolumbar fascia anchors back muscles, the fascia lata envelops the thigh. Fascial compartments can be protective but also restrictive. In compartment syndrome, swelling within these closed spaces increases pressure, reducing perfusion and threatening tissue survival. Understanding fascial planes also guides surgical approaches, abscess drainage, and anesthetic blocks. Lymph nodes filter interstitial fluid return through lymphatics. They are distributed in clusters: cervical, axillary, inguinal, mesenteric, and positioned along major drainage routes. Lymph enters via afferent vessels, percolates through sinuses rich in macrophages and lymphocytes, and exits via efferent channels. Each node processes a defined territory. For example, axillary nodes drain the upper limb, lateral breast, and superficial thorax. Enlargement may indicate infection, malignancy, or immune response. Sentinel lymph nodes, the first in a chain to receive drainage, are critical in cancer staging. Their location is anatomical, their significance is systemic. Anatomical spaces are potential regions between layers or within cavities that expand in disease or intervention. The peritoneal cavity allows organs to glide. In trauma, it may harbor blood or infection. The subarachnoid space surrounds the brain and spinal cord, where cerebrospinal fluid flows and lumbar punctures access pressure or pathology. The retropharyngeal space may spread infection from throat to mediastinum. The popliteal fossa, cubital fossa, and femoral triangle contain key vascular and neural structures, vulnerable in injury or accessible for clinical procedures. These spaces guide where fluids collect, how infections spread, and where interventions are safest. Referred pain is the perception of pain in a region distant from its source due to shared spinal segment innervation. The brain interprets visceral pain using somatic maps. For example, diaphragmatic irritation from a liver abscess may cause shoulder pain. Both share cervical spinal roots. Myocardial ischemia may cause jaw or arm pain. Appendicitis may begin near the umbilicus before localizing to the right lower quadrant. Referred pain reminds us that innervation patterns, not just proximity, shape experience. Recognizing these patterns helps identify hidden pathology when surface signs mislead. Surface anatomy connects all prior knowledge to the external body. It is where the unseen becomes felt. The femoral artery under the inguinal ligament, the liver edge below the costal margin, the trachea midline above the sternal notch. Landmarks include bones, clavicle, spine, iliac crest, muscles sternocleidomastoid rectus abdominis, and features umbilicus, nipples, pubic symphysis. These guide procedures, locate organs, and allow non-invasive diagnosis. Percussion, auscultation, palpation all depend on knowing what lies beneath. Even in imaging, external markers align with internal structures. Surface anatomy is the visible tip of the anatomic iceberg. These final 5 concepts, fascia, lymph nodes, spaces, referred pain, and surface anatomy, are unifiers. They link internal structure to external action, microscopic detail to clinical consequence, theory to touch. They are not always listed in textbooks, but they appear in every clinic, surgery, and physical exam. At the bedside, knowledge of these features changes care. Palpating a firm, fixed lymph node guides cancer staging. Identifying a tense compartment in a swollen limb saves muscle. Recognizing referred pain localizes a hidden infarct. Understanding surface landmarks enables safe injections, fluid removal, or resuscitation. And tracing fascial planes reveals how infection spreads or anesthesia works. A brief reflection: anatomy ends not with a list, but with a lens, revealing how hidden systems shape every visible sign. You close your eyes and feel the shape beneath the skin. Layers, flows, signals, and rhythms. Quiet, ancient, precise. Now your journey through 100 anatomy concepts is complete. Each idea linked, each structure grounded in purpose. Each section building the quiet logic of the body.